راح نستكمل ما تبقى من جراحة الكلى والمسالك البولية، وبعدين مباشرة راح ننتقل إلى الهيماتو-أونكولوجي سيكشن. فإحنا يعني بدنا بس نص ساعة في ديلي، وهذا راح ناخده من وقت البوستر تور، فإحنا إن شاء الله on time. I will ask Dr. Walid Zalloum to just restart the session, the urology session again.
Okay, we continue the urology session. Now from Palestine, Dr. Amjad Sweti. He will going to talk about upper urinary tract urothelial carcinoma. From Hebron Hospital.
Thank you. السلام عليكم، يعطيكم العافية. اليوم بدنا نحكي عن موضوع very important subject in spite of its low incidence, the upper urinary tract urothelial carcinoma. Mainly we will discuss high risk type. As we know, upper urinary tract is a collecting system started from calyces and infundibulum and renal pelvis and ureter. All of them covered from inside with urothelium, which share the same embryological origin and the same condition. Upper urinary tract, in spite of its low incidence, this makes the randomized trial to conduct it is difficult, clinical trial. So diagnosis and management depends mainly on expert opinion and retrospective series rather than quality evidence. Epidemiology, the upper urinary tract is uncommon, as we said, 5 to 10% of urothelial carcinoma, peak incidence from 70 to 90 years, usually multifocal in 10 to 20% of cases, concomitant with carcinoma in situ in 11 to 36%. Synchronous 17 and metachronous in 22 to 47 of cases. 2/3 of the cases at the time of diagnosis is invasive and different from that of bladder. In bladder, there's 15 to 25 at the time of diagnosis is invasive. 9% of patients present with METs. The most common location is usually renal pelvis, and when it comes in the ureter, it's usually in the distal ureter. 90% is urothelian. Only 8% is squamous cell carcinoma. Risk factors, as we know, for urothelial tumor in general, either upper urinary tract or bladder, is tobacco smoking, chronic phenacetin use, cyclophosphamide, chronic inflammation, chemical exposure like arsenic, Balkan nephropathy, which increase the risk from 100 fold to 200 folds. Well-Lyne's syndrome, which is hereditary non-polypose colorectal cancer. Metastasis of the upper urinary tract urothelial carcinoma by different methods. Mucosal extension, which we said, or which by drop metastasis, which means that the urothelial tumor can spread proximal or distal to the primary tumor. Or local growth and hematogenous and lymphatic invasion, which mainly metastasize to the lung, liver, bones, regional lymph node. Lymphatic metastasis from the renal pelvis and the proximal ureter usually to the retroperitoneum, and the distal ureter usually to the pelvic lymph node. Mainly presentation of the upper urinary tract is, the most common presentation is painless gross hematuria, which accounts from 70 to 80%. Flank pain also present in 30% of cases, maybe due to obstruction by clots or by tumor itself, which causes hydronephrosis and pain, sometimes incidentally discovered. Diagnosis of upper urinary tract mainly depends on two tools, which is the CTU and the ureteroscopy. This is the main tools for diagnosis of upper urinary tract urothelial carcinoma or tumors. CTU give you a complete visualization about the upper urinary tract and direct extension, which helps for staging and lymph node involvement. Ureteroscopy also give us a good visualization of urinary tract and biopsy of the tumor for grading to decide later on the modality of management. Sometimes we use the MRI in cases of when there's contraindication for CTU and sensitivity in 70 to 5% of cases. Retrograde biography also in certain cases when there's poor renal function. This is a CTU for a patient came to our department in Hebron Hospital. He is 54 years old, free past medical and surgical history, presented seeking for advice for his incidentally discovered renal mass. Patient was treated by a neurologist for his low back pain. And incidentally, when he did CTU or CT for spine, incidentally discovered renal mass. And he sent to us for medical advice. Patient, when came to us, he has no history of smoking, free past medical surgical, no complaint from urinary system or hematuria. We did the trivasic CT scan and mass in the left renal. Many or more than one radiologist cannot judge if this in the renal pelvis or in the cortex of the kidney. So we did a radical nephrectomy for this patient for histopathology. Then after 1 week, histopathology said this is a type of high-grade invasive papillary urothelial carcinoma. We sent to another histopathologist, gave the same result. So we returned back the patient to our department for another operation, which is ureterectomy and urinary bladder cuff. As we said, the ureteroscopy for visualization and biopsy and degrading. Sometimes in cases of hematuria without visible lesion, we take urine cytology. When there is negative cystoscopy and biopsy, sometimes when there is still urine cytology positive in spite of negative biopsy and cystoscopy, we did wash cytology to differentiate whether it's from the left or the right side. Summary of evidence and guideline for the diagnosis of upper urinary tract urothelial carcinoma. We mainly, as we said, depends on CTU and ureteroscopy for staging and definitive diagnosis and grading. Also, we should do cystoscopy or urethrocystoscopy to detect concomitant bladder cancer. TNM classification of upper urinary tract urothelial carcinoma. As we know, Tx cannot be assessed. T0, no evidence of primary tumor. T1, tumor invades subepithelial connective tissue. T2, tumor invades muscularis. T3, renal pelvis tumor invades beyond muscularis into the pelvic fat or biliureteric fat. And T4 invades adjacent organs. A regional lymph node, N1 metastasis single less than 2 cm or up to 2 cm or less than 2 cm. N2 single more than 2 cm or multiple, M0, N0. There is different factor we are used a prognostic factor for risk stratification of the upper urinary tract for later on to decide the modality of management, either local management, nephron sparing, or radical management, or pre-operative systemic therapy.
2 minutes, Dr. Mahmoud.
البروجنوستيك فاكتور بوست اوبراتيف الادفانسد ستيج والهاي جريد والكارسينوما انسايت والليمفوفاسكولار انفيجن والبري اوبراتيف الادفانسد ايج والكرونيك كيدني واليوتراي ترومر. These factors with other factors for risk stratification according it we depends for the modality of management. High risk we mainly any of these factors present it's considered high risk. Multifocal disease, tumor more than 2 cm, high grade in biopsy or cystoscopy or cytology, local invasion, hydronephrosis, and previous radical cystectomy for high grade bladder cancer. The management of high risk non-metastatic. The main management and the gold standard is a radical nephroureterectomy with urinary bladder cuff for this type of high risk tumor, either open or minimally invasive. Several techniques used for distal ureter resection, none of them shown to be equal to complete bladder cuff excision. Immediate post-operative single dose of intravesical therapy is mitomycin.
Time, Dr. Amjad, time.
Strongly recommended. Metastatic upper tract urothelial carcinoma, when N1 to N3, we usually use systemic chemotherapy. If the patient is stage N1 to N3, treated initially with systemic chemotherapy, and if downstaging done in selected cases, we do radical nephroureterectomy. Systemic agent based on cisplatin, same that for bladder, and external beam for local control of locoregional disease. Neoadjuvant chemotherapy, as we said, prior neoadjuvant for before losing kidney function and downstaging and lower disease recurrence and mortality. Adjuvant chemotherapy, the same cisplatin-based chemotherapy, significant improve in disease-free survival. The only limitation is renal function. The usual regimen is dose-dense INVAC or GC. The follow-up of the patient mainly we depends on, for high risk, perform cystoscopy urine cytology every 3 months. If negative, we continue the same cytology and cystoscopy for 2 years. If negative, we continue every 6 months until 5 years. CTU and chest CT every 6 months for 2 years, and then yearly. Thank you very much.
Thank you. And now, Dr. Mahmoud Allan from Hebron Hospital. He's a senior urologist. He is lecturer in Al-Quds University. He will talk about, he has a case about presentation about testicular tumor. And he will talk an outline on testicular tumor in adult and pediatric. Thank you.
Thank you. It's proud to be here in this conference, and I'm so proud to be in front of my teachers, Dr. Walid and Dr. Wael, and all of the audience. Dr. Abed, most welcome. Today, I'm going to introduce 2 cases of testicular tumor, one about infant testicular tumor, and the other case, it's not rare, but just for discussion. First case, it was a newborn baby, full term, with normal vaginal delivery. He was born at Al-Ahli Hospital, examined by the pediatrician, and he had bilateral minimal hydrocele. On examination, the pediatrician suspected the baby to have intratesticular tumor. It was interesting, really, because when I examined the patient at that time, and I may miss, or anybody can miss, because it was the same as normal. So the pediatrician asked the baby to do, they asked for ultrasound. The ultrasonographer was his opinion that the baby may have either testicular neoplasm or chronic antenatal orchitis. After 2 weeks, the baby was referred to our clinic, and during examination and during the history, nothing was positive except for that the baby had a family history. His paternal uncle had a testicular tumor. Otherwise, the baby has free history. On examination, when I examined the baby, both testes were normal, except that the left testis, there was minimal hydrocele, and it was slightly harder than the right one. Again, we asked the baby to do ultrasound. On ultrasound, we found that the baby has a heterogeneous mass lesion. It was 12 by 11 millimeter, associated with 5 by 6 millimeter cystic lesion. And again, the diagnosis was either teratoma or the yolk sac tumor. As you see, as you see, the cystic lesion, it was 5 by 6 millimeter, and the intratesticular lesion, the heterogeneous or hypoechoic mass, it was around 11 by 12 millimeter. Tumor markers were done, only positive for alpha-fetoprotein, but as you know, neonates, usually they have high alpha-fetoprotein. It was problematic to decide whether it is elevated due to tumor or due to neonatal issues. The case was discussed with the pediatric oncologist, and his opinion was to repeat the alpha-fetoprotein after 1 week. We repeated it, and it became just like from 4,860, and it became 1,080 after 2 weeks. Whole body CT scan also was done, and it was negative for retroperitoneal lymph nodes enlargement, and the only thing was positive that there was left inguinal lymph node enlargement, which is benign looking. So we decided to do transinguinal radical orchidectomy, and the histopathology was mature cystic teratoma. The decision was not easy. Even the histopathologist was not sure about the diagnosis. Again, they sent the plates to Hadassah Hospital to make sure, and the same diagnosis approved. Second case, it is not rare, but I use this case just to discuss the cases about pediatric and adults. It was, he was 25 years old male, presented to our hospital with right testicular mass for 7 months, 7 months duration. He was treated as epididymoorchitis outside of our hospital. When the patient presented to us, we asked him to do ultrasound and tumor markers, and we examined the patient. He had a bulbable testicular mass. So ultrasound done and proved a 3.5 centimeter heterogeneous mass, which was highly vascularized, and there was no cystic lesion in it. CT scan and tumor markers done, and transinguinal radical orchidectomy as well done. And the histopathology proved that the patient to have seminoma. The patient was sent to oncologist, because the CT scan surgery was positive for retroperitoneal or suspicion retroperitoneal lymph nodes of around 1.5 centimeter. As seen here, you see the testicular mass in CT scan and ultrasound, and the retroperitoneal lymph nodes, it was around 1.5 centimeter. Adjuvant chemotherapy, single dose carboplatin was given for the patient, and PET scan, CT scan was done, approved, no recurrence or no any residual of the tumor. Discussion. The incidence of testicular tumors in the children is only 0 to 2 cases per 100,000, and it is less in the neonate period. Testicular tumors are rare in children under 15, and it accounts for 2 to 4% of all childhood cancers. Increased risk of testicular tumor associated with the undescended testis. Testicular tumors are classified into germ and non-germ cell tumors, and all of you know the subtypes, seminoma and non-seminoma, with other subtypes. Testicular teratomas, as concerned, are the most frequent histologic type in the children and are responsible for approximately 50% of the prepubertal testicular tumors. Seminomas are more common in the adults. Histologically, prepubertal teratomas can consist of any combination of the 3 primitive embryological germ cells, endoderm, ectoderm, and mesoderm. Teratomas are poorly or mildly vascularized on color Doppler. Teratomas can occur in the neonate period, although the average age of presentation is 18 months. Yolk sac tumors is one of the commonest tumors in children, and it accounts for 15% of all malignant tumors. That's why it is more common as a malignant tumor, whereas the teratoma is more common. The presentation of testicular tumors, usually if they present with the painless mass, studies showed that up to 1/3 of the testis tumors are initially misdiagnosed with the epididymoorchitis or hydrocele, as the case we discussed. Histologically, these are the subtypes of germ and non-germ cell tumors, seminoma and non-seminoma. Some of them produce alpha-fetoprotein and some of them beta-HCG. Ultrasonography, it is the gold standard diagnostic for testicular tumor. Doppler ultrasound findings may mimic focal diffuse orchitis, and the clinical data are necessary for the diagnosis. MRI can be used sometimes for differential diagnosis. Testicular microlithiasis. It's an important issue because testicular microlithiasis, they have the risk of malignancy, or they don't have there is no agreement for the management and monitoring of the patient with testicular microlithiasis. So it might be associated or with malignancy or not. It needs more studies. Seminoma, again, one thing is important about it. Seminoma is uncommon in children, but in ultrasound, it is usually associated with hypoechoic and can be lobulated or multilobular, and it is associated with high vascularity. That's why it can be misdiagnosed with the orchitis. Only two slides.
Already 12 minutes.
Germ cell tumors, it is a precursor of the testicular tumors, except in the neonates, just like prepubertal type of teratoma and yolk sac tumor in premature, in prepubertal, and the spermatocytic tumors in adults. It's very rare in children, and it is usually not associated with the undescended testis, only in 5 to 8% of the cases. These are the risk factors for the testicular tumor to metastasize. In seminoma, the size should be more than 4 centimeters, and invasion for the rete testis. In non-seminoma, lymphovascular invasion if present, and embryonal cells. Adjuvant therapy after radical orchidectomy, usually either we go for radiotherapy in case of seminoma, but nowadays we use the chemotherapy because it is less toxic, and we go for retroperitoneal lymph nodes, and we try to be nephron sparing. I'm not going to talk in details. Conclusion and recommendations, this is the very important slide. Testicular tumors need multidisciplinary efforts for management. Testicular teratomas may transilluminate, just like the baby who had hydrocele. Primary health care providers should pay much more attention for the undescended testis, and they should refer the cases of undescended testis for the specialist before the age of 1 year. And they should be strict to the guidelines, not like as we see they sometimes refer the patients after 3 or 4 years. They should be strict to the guidelines. Timely and accurate diagnosis of scrotal swelling is essential for the treatment decision. Ultrasonography, color, and the tumor markers should be done. When we need more experience with the pediatric testicular neoplasm, and this experience may need even globally. Thank you very much.
Thank you.
Okay, so I would like to introduce now Dr. Nidal, who has recently finished his fellowship at the United Kingdom at Cambridge University Hospital. He's going to talk about endoscopic management of upper tract TCC. So welcome Nidal to النجاح National University.
Thank you first for this kind invite. I'm so proud to be here. Mainly my teacher, Mr. Abu Arfa, is one of the audience. I'm going to speak mainly about the endoscopic management of low-risk upper tract urethral carcinoma, which is called the kidney sparing approach. I need your help first with this. Oh, okay, that's fine. So, according to these guidelines that have been taken from the European guidelines, we are finding that there is a main part for ureteroscopy in diagnosis as well in the treatment or management. And in this lecture, I'm going to speak mainly about the 3 tricks for optimal endoscopic management. First of all, which patients that should go for this kind of treatment, and there should be kind of equation between patient selection and risk stratification. And we can see, according again to the guidelines, that the patients that should go for this kind of treatment is the patient with low risk UTUC, which is unifocal disease with tumor size less than 2 centimeters, with negative high-grade cytology, low-grade ureteroscopy biopsy, and there is no invasion on the CT. You can see on the other side of the slide exactly describing how it should be on the CT, on the pathology, and if we can play that video, that will show you how it looks like the unifocal. Okay, that's fine. Okay, next, that's fine, we can continue, that's fine. And the next thing we are going to speak about it is which instrument do we need for this kind of treatment? And let's start with the vision. And we're usually going to use what we call small digital scope files. What does we mean by small digital scopes? It's an oval tip and oval shaped design. The shaft smaller than the tip. And this will improve your irrigation and drainage. For the screen, we usually use a technology called image enhancement technology. And there is 2 technologies describing this. The first one's from Olympus, which is called Narrowband Imaging. The other one from Carl's, which will show it in the next slide. The good about this kind of vision that it makes some kind of differentiation between irritations and UTUC. You can see those black spots, which is called the egg frogs, which makes some kind of differentiation between the UTUC and irritation. The other technology, which is called Professional Image Enhancement System from Castos, and this kind of image, we use the color, chroma, and spectra beam mode. If you can play those videos, that would be helpful, so you can see what is the difference between the scopes and the digitals one. Yeah, you can play one of those. Okay, so we can see that we'll be going to change in the setting. We can start seeing that the tumors start to be much more clear. Can we play the other one, please? And this is how it's before, and this is how it looks like after. The other thing what we need for this kind of procedure is the irrigation, and we usually trying to use the low pressure. We usually should avoid doing aspiration because this could increase the bleeding, and we're usually going to do it slowly and gently. And if you're going to play this video, the lower one, you will find that in the beginning it's going to be difficult to see. After 1 minute, it will start to be much more clear, and if you wait for 2 minutes, it will be much better. So you should take your time before doing this kind of procedure. The other instrument that we should use here is the basket and the forceps. For the basket, we usually use it for papillary lesions, and for the forceps, we usually use it for flat or solid lesions. And if we can play the video down, this is mainly describing how if there's like a tumor in the ureter. It's complicated. If you're going to pull it, this will go urethral stripping. So the right thing is just like to push it inside the kidney to detach it, and then you can remove it. For the histology, it's important to know that these specimens are usually small, so they are insufficient for diagnosis. And there should be kind of confusion between inflammatory stones, foreign bodies. And the sensitivity is usually higher for the high tumor grades. For the energy sources, we usually use laser, and we have got in the market 2 technologies. The first one is called the Homonym Laser. We use the setting of 10 Hz, 10 joules. We usually use the untouched technique to decrease the risk of bleeding, and we usually use as well the lateral diffusion to avoid some kind of perforation. If you could play this video, you will show how we can use this kind of techniques. One important last thing, the transitional step, we usually cut it. This will make your vision much more better. The other energy sources that we got it in the market is called the thorium laser fiber. And if we can play this video, it's a kind of comparison between holmium laser and the thorium laser. With the thorium, you will find that the bleeding is much less, but there's like more necrotic tissue. So on this side, you can see the thorium laser. On the other side, you can see the holmium, and you can see the difference in between these 2 technologies. How we do it? We usually start with the cytology. It's a beginning procedure. We usually do it before contrast. We usually do it before using of kind of manipulations. And if you got the results of false positive, it's usually because you take it from the walk-in channel of the ureteroscopy. The second thing we're going to do is the ureteroscopy itself, and we usually use the non-touch technique. And it's because we're going to decrease or to minimize the guide wire trauma. You can see on that other slide how the wire could cause some kind of trauma. But again, you should walk more safely. If you think that you prefer to do it with wire, you can do it with wire. We usually avoid using the access sheath, and we usually do it under the general anesthesia because we're using the apnea protocol. There's 2 videos here. If we can play the video in the middle, please. This is how we usually do the flexible ureteroscopy without using a wire. It's called the non-touch technique. So we go to we tilt the scope, and then we go to the orifice without using the wire, and then we start introducing that scope gently. The other slide, the other video on the down, it's make some kind of comparison between using the protocol of apnea. You can see how the kidney is moving, while you're using the apnea protocol, it's less smooth. Again, in endourology, there's nothing called never or always. This is how we usually do, but you can do it in the way you think it's much right. For the follow-up, according to this nice paper that has been done by one of the pioneers in the endourology, Oliver Trexier, we can see that the second look should be in the 6 or 8 weeks after doing the procedure, and in this way, you can decrease the cancer, you can increase the cancer detection rate in about 50%. I'm going to finish, it's like 2 slides. Some considerations. The first consideration that we're going to talk about it is there is a place to give antegrade or retrograde BCG or metamycin or even the UGN 101. There is no clear answer for this first consideration. The second consideration about giving a single intravesical dose of chemotherapy, if there is any help in this part. According to this nice paper that has been published from Guy's Hospital, we showed that if you're going to give a single dose of metamycin, this will decrease the risk of recurrence in the bladder about 100%, or about 11%. The third consideration about taking biopsy is that going to increase the risk for bladder tumor, and you will find that, yeah, according to the second paper, it's going to be do it double-fold. That means going to increase it twice. So we still have no answer about the indications or the needs for giving the chemotherapy for intravesically for the patients after doing the ureteroscopies. My take-home message from all of this is kidney-sparing surgery is usually good for the patients with the low risk, and you should do an appropriate assessment before choosing your patients. Thank you.
Thank you very much, Nidal, for this nice presentation. I'm not entirely sure. I think Dr. Abu Marzouk is with us from Qatar now. Professor Abu Marzouk, he is a professor at Glasgow University, and he works currently at Qatar or Hamad Medical Corporation as a urology consultant and the head of the research unit there. Omar, can you hear me? Omar? Is he on? Hi, Omar.
Can you hear me? I could hear you.
Yes, I can hear you now. Welcome to this nice virtual meeting. I can see you, but I can hear you. So if you are not visible, you can proceed with your presentation.
I don't know what's going on. I mean, I could see myself in this nice, lovely picture, and I can see the audience.
Great.
But for some reason, I don't know why you can't see me.
I think until we can see you, you can proceed with your presentation if you want to share and just start.
Okay, Dr. Arula, do you mind uploading it?
السلام عليكم ورحمة الله وبركاته. معكم الدكتور عمر موسى أبو مرزوق. I'm a consultant urologist and robotic surgeon at Hamad Medical Corporation. I'm a mentor as well as a proctor for robotic surgery, and I'll be presenting an overview of robotic surgery internationally as well as across the Middle East. Today's talk will encompass an overview of the global trends in robotic surgery, as well as Middle East installation and an ecosystem of the Da Vinci system. Traditionally speaking, open surgery has always been the go-to for many surgeons for any surgical procedure. However, as technology advances, so does surgical technique and practices. Laparoscopy was introduced as a replacement for open surgery as early as the 1990s, and many complex procedures were then performed laparoscopically. However, at the turn of the century, robotic procedures using the robotic Da Vinci system have slowly taken over not only laparoscopy, but as well as open surgery in complex cases. As technology and engineering advance, we will see more improvements in the robotic system, as well as possibly artificial intelligence inclusion and automation. Currently, the robotic system is used in over 69 countries and over 6,700 machines have been installed for well over 10 million procedures. And only in 2021, there was about 1.5 million procedures using the robotic Da Vinci system. Currently, there's over 60,000 robotic surgeons, and this has not only improved through evidence-based medicine, the practice and usage of this technique, but also multiple studies have shown its advantages over laparoscopy as well as open surgery. A brief timeline over the last 20 or so years, you could see that the original Da Vinci system was quite cumbersome. But however, as advancements in technology as well as engineering progressed through the years, the Da Vinci system has eventually led to a single port system, which is currently being rolled out. Nonetheless, the Da Vinci Xi is currently the model of choice for many of surgeons. As a urologist, I'd like to presume that we have championed the robotic system for many years. However, since its inception, it's been used in gynecology as well as general surgery. And as you can see from the charts, in fact, the general use of the robotic system in general surgery as well as general surgical subspecialties have significantly taken over the mantle of its usage. And with time, we envisage all surgical specialties to utilize the robot in one way or another. To show an example of how robotic surgery has replaced laparoscopic or even open surgery, this slide shows that in the United States, over 90% of prostatectomies as well as partial nephrectomies are conducted through the robotic system. Nearly 80% in the UK for both surgeries. Germany, Korea, and Japan also slowly progressing toward replacement of laparoscopic and open procedures. And this trend is exponential, and we envisage that across the board worldwide, the robotic system will be utilized more proficiently. This is essentially due to the evidence provided that robotic surgery does provide better patient outcome intraoperatively as well as postoperatively and in the long term functionally. Although the Da Vinci system was the first robotic system to be used in surgery, in the last few years, multiple companies have tried to emulate it. One in particular, the CME Surgical, has also developed a robot which is currently being used in over 30 centers across 8 countries, and thus far have produced or have conducted over 1,500 procedures. Another type of robot that has been developed is the Medtronic Hugo system, though as of yet it's only been licensed for urological and gynecological procedures, and it's only been utilized in 2 countries for about 100 or so procedures. However, I envisage that with time, this will increase. The Mantra robotic system is currently undergoing trials and has not been fully established as a replacement for the current standard of the Da Vinci system. However, again, with time and further trials, we will see the results. The previous 3 slides have shown that there are other systems being developed or have been developed worldwide, and currently there is estimated to be over 20 companies working on a version of a robotic system. Nonetheless, the Da Vinci system remains the most widely used, and therefore, looking at the Middle East, we could give you an overview of where these systems are available. As you can see, across the Middle East, the 5 countries utilize the robotic Da Vinci system, either an older model or the newer model, and all have quite high success. And in fact, multiple publications have been generated to show the improved performance of the robotic system over laparoscopy as well as open surgery. Despite what us surgeons would like to think that we are the center of the universe, though in this slide it does show that the surgeon is the center, nonetheless, there are many teams that are involved in implementing a good robotic program, and not only performing the operation and the procedure, but also taking the robotic innovation forward. As you can see, it involves the surgical team, scrub team, as well as innovation and integration, utilizing various technologies to even better improve surgical technique. And of course, these will require training and education through various models. And of course, finally, the support system and analytics for the hospital as a whole, as well as the referral system to be able to take advantage of the robotic usage. In the next few slides, I'll be showing how many of the current laparoscopic tools that we use have been developed for the Da Vinci system, and not just its usage, but also have surpassed the original laparoscopy equipment. Although very dependent on surgical practice, stapling of vasculature or bowel is currently implemented across many procedures. For example, in urology, I use the staple for the hilum almost exclusively. I've not used a clip or a wet clip for a number of years now, and I've not had any problems. Using the Sureform robotic stapler gives me the advantages of the endo wrist, and which essentially means I could rotate the staple to suit the exact position of how I want the staple line to take, as well as overcome any abnormal crossing vessels or different positions. In the next few slides, I'll give you an example of that. As you can see, using the robotic stapler, you have multiple angulations that you could position how you want the staples to take the tissue target. Interestingly, having trained as a laparoscopic surgeon, I do recall many instances where we required multiple staples to control a hilum due to the aberrant or inappropriate directional installation of the standard endo GIA. Having used this staple, I've not had any problems in positioning it, and in fact, usually one fire per vessel was quite sufficient. I love this piece of equipment. This is the Force Bipolar. It's not only a fenestrated atraumatic grasper, but also a bipolar grasper. It's quite gentle on bowel, and therefore I could manipulate bowel quite easily without causing any damage or trauma to it. I could also dissect with it due to its jaw, that it opens, not only one jaw opens, but both jaws open in both directions. In addition, that it is a bipolar, uses bipolar energy.
Now, this is an interesting debate for those out there who like the ligature versus the harmonic. I am very personally impartial to the ligature system, and throughout my training in laparoscopy as well as subsequent practices, I've exclusively used nothing but the ligature system, blunt-ended. I would dissect and as well as energy throughout the whole procedure.
Sorry, 1 minute, we have to finish the presentation.
Given the advancements in Da Vinci's technological systems, they've also developed their own versions. So you have the vessel sealer, which again comes in 2 different sizes, but is as equally efficient as the ligature system, if not more so, given the technology it provides. In addition, for those who like harmonics, they'd have a harmonics version called the SynchroSeal. This is one of my favorite pieces of technology implemented with the robotic system. Although it's not been widely installed in systems yet, it's only recently hit the market. You could
we need to, I'm sorry,
install
I think we need to
an
stop
iPad
here.
or through even your phone, a 3D modeling image of.
And we will have Omar, I think, on Zoom with us, and I think we need to open the discussion.
I have a question to Dr. Mahmoud. Dr. Mahmoud, the first case, neonatal testicular tumor. I think the kid has been delayed in his treatment for long period because in the first he was born in Al Ahli. After 1 week was referred to Ali Hospital, where an ultrasound showed echogenic mass, clinically hard mass, and alpha-fetoprotein 4,000 something. Differential diagnosed ultrasound is Yolk sac tumor or teratoma. Both of them is indication for orchidectomy. Why you didn't do it straightforward? Why you have to postpone for 2 weeks till you will wait? I mean, this was the recommendation of the oncologist, which I think is very wrong. Sorry.
Discussion the case with the oncologist. Why late? I decided to do the radical orchidectomy straightforward for the baby. And I discussed the case with the pediatric oncologist, urologist from US, and we decided to do even the case straightforward. But the family disappeared. The family disappeared. But you did mention that disappeared. You said that we follow them after 2 weeks. You asked them to be followed after 2 weeks. Even in spite that the oncologist decided to delay the case, the family disappeared for even 3 weeks. And you know, to do CT scan for a baby who has 2 weeks age, it is maybe the kidneys cannot tolerate the dye. That's why we delayed the CT scan. But unfortunately, the family decided not to do the case until the baby became 7 or 8 weeks. I don't remember. Dr. Mahmoud, it is the physician's duty to convince the family about the urgent situation. Testicular tumor should be dealt on as an urgent basis always. This is my message. Yes, of course. Once diagnosed, they should undergo radical orchidectomy. But the evidence proved that most of the cases of infants are benign cases.
Mahmoud, what's the benefit from repeating alpha-fetoprotein? Why you repeated within 1 week?
Alpha-fetoprotein usually
before surgery.
Alpha-fetoprotein usually is high in neonates. It is the normal range in a neonate, it's around 40,000. When we asked the patient to do the alpha-fetoprotein, it was around 4,800. I don't know, the oncologist decided to repeat the alpha-fetoprotein just to make sure. In spite, it was not indicated to do it.
Your decision was dependent on
repeating alpha-fetoprotein after surgery is mandatory, just for follow-up, and it was normal.
Thank you.
But the message again for the GP and for the students, strict to the guidelines, especially for those patients who has undescended testis.
Okay. Any other questions from the audience, Dr. Wael?
Thank you, Dr. Faris. My question is for Dr. Nidal. How you follow the patients after resection of small tumors from the renal pelvis or upper ureter? There needs a follow-up. This is one. Two, when you grasp the tumor by basket or grasping forceps from the upper ureter to the lower ureter to the bladder, you don't think that the tumor will produce a seeding of tumor cells through the long way from the upper to the lower ureter?
Thank you, my teacher. So, for the first question about the follow-up, the second look should be in between the 6th and the 8th week. The follow-up should be like 3 months after doing the procedure. It could be a ureteroscopy together with cytology. And then you increase the interval depending on the negative. That means once you start to get a negative cytology after 6 months, you can increase it, instead do it 3 months. You can do it 6 months. Later on, you can do it for 1 year. For the seeding part, this is a good point, and we have no answer for this because we still, after doing this kind of procedure, we're putting a stent. Does the stent increase the risk for seeding? No one knows. But I think, yeah, there is a risk for seeding after doing this kind of procedure. But taking in consideration, you need a biopsy to make a diagnosis, and doing this kind of procedure may change it from over-treatment, I mean from doing a ureterectomy to under-treatment, which is doing kidney-sparing surgeries. Thank you.
Finish.
And seeding almost happening daily with urine.
Okay, any other questions? Okay, thank you very much. I think we have to finish the urology session today. Thank you very much for every single urologist who has managed to attend this session. And we are not going to take any coffee break. We will start directly with the hemato-oncology session. So thank you, Dr. Walid. Thank you, Dr. Murad, for moderating this session. It's a pleasure to have you here at Al-Najah National University. And I would like to invite Dr. Hussam Salame, Dr. Majdi Zaid, I think also Dr. Husni Maqbool. I'm trying to find you. Okay, to moderate the next session. So please put your hands together. Okay, Dr. Majdi is not available. Can I invite Dr. Sultan to come to the... Oh, yeah. You moderate 2 sessions now, yeah? You are lucky.
Good evening, everybody. It's my pleasure, actually, to introduce to you Dr. Riyad Amir, not only because he is good-looking, but also because he is my friend, and most importantly, he is a consultant hematologist, and he was among the first to establish proper, I believe, hemato-oncology, as well as bone marrow transplantation services in Palestine. Please welcome Dr. Riyad Amir for his presentation.
السلام عليكم. السلام عليكم. الصوت واضح. بحاول briefly to present the Palestinian experience in bone marrow transplantation. In Palestine, we only do autologous transplant. That is, we call stem cell rescue. high-dose chemotherapy with the stem cell rescue. It's estimated that around 100 to 140 Palestinians will need such transplant or such procedure every year. The majority previously were treated outside Palestine, like Jordan, inside the Green Line, and in Egypt for the Gaza people. This is the first transplant which was carried in 2006 at Al Arabi Hospital. A patient who suffered from Hodgkin's lymphoma, and this is our initial team. And here he is ممثل في التلفزيون الفلسطيني حاليا. هي صور حديثة له. بعرف شاي شفتوها المسلسل تبعه برمضان بيجي. المريض الثاني اللي زرعناه في 2006 بنت اسمها ريم من حوارة، لا زالت ممتازة. وزرعنا لكمان اثنين، للأسف واحد منهم relapsed mantle cell lymphoma who died 2 years later, and one patient died after 3 months of autologous transplant. Experience at the NNUH اللي بلشت في سنة 2008 عفوا في شهر 8 2014. بدأت في أول مريضة كانت multiple myeloma وأخذت العلاج اللي هي بسموها consolidation bone marrow transplantation. الداتا اللي جمعناها لحد جولاي تقريبا 2022 بنسميها هاي دوز كيموثيرابي وستيم سيل ريسكيو. ممكن تجيب لي الميكروفون وتحرك من مكان اللي عليك في ميكروفون ثاني عندكم؟ First transplant was in June 2014. كملنا تقريبا 250 حالة لحد نهاية 2022. The majority of cases for transplant were multiple myeloma. They represented around 50% of cases, 40% for Hodgkin lymphoma, and non-Hodgkin lymphoma around 10%, and other cases 2%. They included AML M3, mantle cell lymphoma, and retransplants. A range of age from 16 to 70 years, the median age كان 33 years. الفيميل male distribution كان majority male حوالي 55%. الفيميل 45%. I don't know the reason behind this distribution, but this is a fact. Patients from the West Bank around 2/3, 60%, 40% from Gaza. Potential candidates of selection of patients for Hodgkin lymphoma for transplant, any relapse or primary refractory, or other bad conditions like progression, secondary refractory, any relapse are indication for transplant. Performance status must be excellent, 0 to 1, age up to 70 years. We initially started doing the age of up to 60, but later on, when we had some confidence, we increased the age to 70 years. And I'm sure we will be able to increase it to 75 or even more. Multiple myeloma, it can be a first-line treatment as a consolidation for response patients with multiple myeloma, 70 years or less of age. Performance status must be 0 to 1. Renal failure is not a contraindicated. It might be strongly indicated in patients with renal failure secondary to multiple myeloma. Pre-BMT workup, routine pre-BMT, we made it very simple. The blood count, chemistry, liver, enzymes, kidney function, echo for the heart, lung function tests, serology for different viruses, including CMV, EBV, varicella, hepatitis, HIV. We stopped doing HIV because no cases of HIV confirmed, but we still do it at the time of blood transfusion. For any patient who needs blood transfusion, we do the HIV. The CMV patients, all the 250 patients were CMV positive. No single patient was CMV negative. We did blood cultures and swabs at 3 different occasions, especially the swabs from the skin, groin, axilla. and different places. And we do staging for the original disease, consent form with the patient, and explanation to the family. الستيم سيلز يعني بتمر بعدة مراحل من الموبيلايزيشن الكولكشن للبروسيس processing والستورج and infusion. The processing and storage I want to talk about. We know that most of the centers they use gradient freezing system. We only use standard freezer, a deep freezer of -80. This technique we took it from Italy. They don't use a gradient freezer in the usual setting. They just use a -80 degree. They mix the stem cells with DMSO and albumin and just put it in the freezer, leave it there for at least 5 years or 10 years. The viability testing for the stem cells remain very high, very good, even after 5 or 10 years from such storage. Okay. Stem cell mobilization usually happens after one cycle of chemotherapy, of the consolidation chemotherapy, or we sometimes give a special cycle of high-dose cyclophosphamide to be followed by high-dose filgrastim, and then 5 days or 6 days later by stem cell collection. The minimum number of stem cells needed are around 3 million per kilogram of body weight for each patient. Sometimes we go less than that, around 2.5. The lowest number we use is 1.9 for a patient with multiple myeloma. The same thing for multiple myeloma, but we normally use high-dose cyclophosphamide as a mobilizer, then filgrastim, and the same thing, we need 3 million stem cells per kilogram. This is the stem cell collection. The machine will separate the different sites of cells and then keeps the mononuclear cells, which harbors the stem cells. This is another machine, a different machine. And then usually we take between 1 and 6 sessions. It mean was 2.4 sessions for collecting enough stem cells. Average time between 2 to 4, usually around 3 hours for collecting each session of stem cells. Conditioning regimes for transplant. 90 patients for Hodgkin lymphoma received either BM or LIM. We initially started to use BM, which is BCNU. When it became unavailable, we started to use lomustine instead of carmustine. So the patients were, most of them received LIM or BM. 2 patients received high-dose melphalan. Day -1 is a rest day, which means the day before stem cell reinfusion. And on day 0, the stem cells infused after over a very short period of time, around 6 minutes or 7 minutes for each bag. The same thing with non-Hodgkin lymphoma. Conditioning was with BM or LIM. Sometimes we gave rituximab, sometimes we don't give. The same principle with rest and D0. Multiple myeloma, the standard dose is high-dose melphalan, 200 milligrams per meter square, infused over 30 minutes. Occasionally, we reduce the dose to 140, especially those patients with renal impairment or they have comorbidities. Results, this is the infusion of stem cells. Supportive care, blood products, platelets, red blood cells, antimicrobial treatment, either prophylactic, empirical, or culture guided, and GCSF support, filgrastim support. Prophylactic antibiotics, we use either ciprofloxacin twice daily or levofloxacin once daily, acyclovir 400 milligrams once daily, fluconazole, either we use 400 milligrams IV once daily or 450 milligrams oral once daily. They were given at the same time. Mouth care, clean diet, strict isolation, and strict visitors policy. For any fever lasting for more than 30 minutes, above 37.7 or more than 38, we start our first-line antibiotic therapy is tazocine or tazobactam with piperacillin, and we add amikacin. If they have a central line and we suspect central line infection, we add vancomycin. And if they remain febrile after a few days, we consider antifungal. This policy was changed in the last 2 years when we had a team member added to our team, who is Dr. Ali Sabatin, an infectious disease specialist. He follows the antibiotics and the treatment for infections and sepsis with excellent results. Neubogene or filgrastim, we use 300 milligram twice daily, starting from day 2, not from day 1, and given subcutaneously. Blood transfusion. Blood transfusion we only give when the blood drops below 10 or below 8, or sometimes below 7. Platelets, we are very conservative with using platelets, but we might use it below 10 and usually below 5. We don't give irradiated blood products. We don't have an irradiator machine. Unfortunately, we never had any case of transfusion-associated graft-versus-host disease. We either give single donor platelets or we give random donors. We don't have or we don't give any special precautions for the platelets. We don't give CMV negative platelets or HLA type platelets or things like that. All of the patients respond to standard platelet transfusion. This is the first patient transplanted at Najah University Hospital. This is another patient from Gaza. The outcome. الريسبونس او الريكفري يعني بنعتمدها لما يكون 2 successive days of 0.5 for the white cells وكان المين ريكفري for white blood cells 12 days. الرينج between 9 and 19 days. فبياخذ الوايت بين day 0 the day of transplant up to the recovery حوالي 12 يوم المعدل. For the platelets recovery it took a longer period, about 17 days. Some patients took up to 50 days for recovery to the platelets to reach above 25 on 2 successive days. The range of stay in hospital is around 18 days. The average between 12 to 40 days. Only few patients who stayed more than 30 days. The majority will leave within 3 weeks of stem cell infusion. Mortality and morbidity of the transplant. Mortality, any patient who dies within 100 days of transplant is related to the procedure. Even if he dies by a car accident or an MI, he will be counted on the bone marrow transplant procedure. The overall mortality was 3.2%. That's the patients who died within 100 days from the transplant. Majority were infection, sepsis, 2 patients with organ failure with infection and sepsis. 1 patient had an acute MI after 83 days. So the total number who died within the procedure period is 3.2%, 8 cases out of 250 cases. There are other, this is not important, we'll move on. We have 2 patients who developed massive PE and massive DVT, needed thrombolysis, and some of them just needed low molecular weight heparins. Depression, 1 patient developed severe depression and wanted to commit suicide, but passed freely. Post-transplant care, we give Salbrem for 1 year, acyclovir for 1 year, and we give thalidomide for multiple myeloma patients for 1 year or even more, depending on their tolerance to the treatment. الأوفرall survival لحد الآن بنقدرها بحدود 85%. We don't have accurate result because of the distribution of patients. Some of them are from the north, some from the south, and some from Gaza. We don't know much about their life, and this might be an area of research for somebody to take their telephone numbers and contact them, and we could get a better idea. This paper was published a few weeks ago about infections in autologous bone marrow transplant at the Najah National University Hospital. This is our team. Second version of our team, our future team, and thank you.
Thank you very much, Dr. Riyad. We'll leave the question for the end of the session as usual. Our second speaker will be presented by Dr. Hussam.
Our second speaker will be Dr. Salwa Saadi. She is our guest from Jordan. She is a consultant in medical oncology, myeloma, leukemia, and bone marrow transplantation at KHCC. She will speak about allogeneic hematopoietic stem cell transplantation in patients with acute lymphocytic leukemia. Welcome, Dr. Salwa.
Thank you so much for having me. It's actually a pleasure being here. It's very difficult to talk about transplant in ALL patients within 15 minutes, so I tried to compress my talk as much as possible. So I'm going to concentrate on indications of transplantation, allogeneic stem cell transplantation in patients with ALL. So when we talk about indications, we first need to stratify our patients, know that they are two different, completely different diseases, looking at patients with Philadelphia positive ALL compared to those with Philadelphia negative ALL. We'll start with the Philadelphia positive ALL just because it's more straightforward. So the standard of care up to this point is that all patients with Philadelphia positive ALL need to undergo allogeneic stem cell transplant in first remission. That's the standard of care. Now, are there any exceptions to this point? Yes, there are. We have very good data from our pediatric colleagues stating that a lot of patients, or some patients, can actually forego the transplant process. However, we cannot extrapolate data for adults the same. ALL in pediatrics and adults are completely two separate diseases. The other thing is that pediatric patients actually undergo much more intensive chemotherapy than what adults can tolerate. And so not everything that we see in pediatric patients can be extrapolated into adults. However, there is some early data from MD Anderson that is very promising for patients who receive remission very early on in their treatment course, that we can probably omit transplant in those patients. Very hopeful to see how that turns out in the future. Now, for patients with Philadelphia negative ALL, that's a very different story. Data is not as clear as which patients need the transplant, which patients benefit from transplant. To better decide on which patients need to go to transplant, we usually try to risk stratify our patients. We have several systems for stratification. The first one is looking at clinical features. Of those factors, we look at elevated white blood cell count, older age, CD20 positivity, time to remission more than 4 weeks from start of induction treatment, CNS involvement, and MRD positivity at time of induction. And what we mean with MRD is minimal residual disease positivity. I'm going to talk a little bit more detail about the white blood cell and MRD positivity. These are the two most and better established risk factors, clinical risk factors for patients with ALL. So for white blood cell count, the definition is more than 30 for patients with B lineage ALL and more than 100 for patients with T lineage ALL. Again, B and T lineage ALLs are two completely different diseases. They're not one entity. Those are the numbers that we considered high risk for patients with ALL. Most studies that defined high-risk ALL with those numbers are also derived from our pediatric patients. How much of that can be generalized to adults is unknown. What looks like in adults is that white blood cells are really kind of a marker of which patients are high risk to have residual minimal disease after induction. So we don't know if it's the number exactly or the fact that these patients with high burden disease, it's more difficult to get into remission from first induction. And this takes us to the second point of MRD positivity. So it's important to understand what MRD is and how it is tested. It used to be that patient has ALL, they get induction chemotherapy, we send the results post-induction to our pathologist, and the patient is in remission. So we're excited about patient getting into remission really early on, and some of them are not given adequate reconsolidation or sent to transplant because they achieved remission. Right now, with the current available technologies, we know that some of those patients, when we look at them at a deeper level, a molecular level, some of them don't actually have remission. They just still have some disease left out there. And this disease is what increases the risk of relapse later on after consolidation. And so this minimal residual disease actually changed the way we look at our leukemias and changed the treatment paradigm for these patients. It is important, however, when we look at the data out there regarding MRD, that the time of testing, the degree of what we call positive versus negative is really dependent on the regimen we use for induction. It's dependent on the type of acute leukemia the patient has, and also on the way we test for it. There are different ways to test for MRD. They look at different levels of response, and the definition of MRD positive is really dependent on the method we use to test. It is important, another important point regarding MRD is that patients with MRD positive disease, although we know these are the highest patients that probably need to go to transplant, if we take them to transplant with this MRD positive disease, the outcome is worse than if we give them another line of treatment that turns them into MRD negative disease. The problem is these medications are very expensive, they're not easy to use, they're not readily available in our part of the world, in the full MENA region mainly. Even in more developed countries in Europe and the United States, there are very expensive medications, and some patients just can't even pay the co-payment. So not every patient with MRD positive disease actually get those rescue medications going to transplant. The second part of risk stratification, we look at our cytogenetic and molecular stratification. This is the newer part of medicine as opposed to the morphologic high-risk features that we talked about in a moment. So this table is adopted from the NCCN guidelines. Anyone can look at it. These are the main cytogenetic and molecular changes that we fully understand, or we think that we fully understand, that kind of help us to stratify our patients into high risk and standard risk. The first group, hyperdiploidy, 51 to 65 chromosomes, and some translocations. These patients, usually when they get induction chemotherapy, it's easy for them to go into MRD negative disease. This, as opposed to the second part, the second group, you can see a lot of numbers and a lot of abbreviations. These patients, usually it's very difficult to get them into remission. So what we're talking about right here, we're going back to the MRD part, is that the importance of the cytogenetics, just as the importance of the white blood cell count, it gives us an idea of which patients will achieve MRD negative disease from first induction. It gives us an idea of which patients will have a prolonged remission. A lot of studies out there studying the role of transplant in ALL. I didn't put the studies as much as looking at the meta-analyses that group multiple studies and kind of give us idea what the benefit of transplant in the patients and adult patients with ALL is. And here we're talking about Philadelphia negative ALL. So as you can see, first paper, 2013, it included 13 clinical trials, almost 3,000 patients. There was a survival advantage only in patients less than 35 years of age. So the conclusion of this paper was don't do transplant for anyone more than 35 years of age. In this paper, they didn't see any difference by risk group. So what they basically said is you don't need to stratify your patients. Anyone less than 35, take them to transplant. Anyone older than 35, don't offer. The second meta-analysis, 14 trials, 3,157 patients. There was an overall survival for all patients. However, their survival advantage numerically but not statistically more pronounced in high-risk patients. So what they say, if the patient is high-risk, regardless of the age, take them to transplant. Patients with standard risk probably won't benefit from addition of transplant. Third paper, 2010, 13 trials, 2,648 patients, stratified into standard risk versus high risk. So they found an overall survival for all patients. However, when they stratified them, they found that the survival advantage was just for standard risk patients. What they concluded in this trial that high-risk patients are going to do bad regardless of what you do to them. So maybe addition of transplant is adding morbidity without definite addition of any benefit. That's in contrast to the fourth paper, meta-analysis of 7 trials in 2006, included 1,274 patients. They found a survival advantage overall for all patients, but then when they stratified them, they said that the advantage is actually more for the high-risk patients as opposed to the low-risk patients. And so what did we come up with that? It's confusing. Simply, it is just confusing. We don't have any strong data to support any one modality or which patient should or should not go to transplant. Now, the reason for this inconsistency in data is that the definition of high risk is not consistent across trials. So we set up some of the morphological high risk features. We said, for example, age. Now, what's the definition of older age? Some trials considered 35 as a cutoff, so anyone more than 45 is considered high age. Some patients considered 55 as high age. And so when you try to lump these trials together and come up with a conclusion, the patients are not uniformly distributed within them. So what defines standard risk and high risk is not uniform. The second is most trials did not incorporate what we know right now as high cytogenetics, the table I put over there. The only factor that was consistent in cytogenetic analysis across all papers was the Philadelphia chromosome. So when we look at Philadelphia negative, we didn't know some of these cytogenetic changes at the time the trials were undertaken. A very important point after that is there is no actually true randomization between the two arms. Most papers use something called genetic randomization. So what they did is when a patient with ALL comes and they're offered transplant, the first thing you would do is search for a donor. If the patient has a donor, they're allocated into the transplant arm. If they don't have a donor, they're automatically allocated to the non-transplant arm. The problem with that approach is at the time of the trials, they only used to do match-related donors. So whatever patient comes in and you want to search for donors, you first go to the siblings. Older patients have older siblings, so older patients have potentially older donors. The standard at a time of most of these studies were undertaken in the early 2000s was that anyone over 55 was not considered a donor. So what they automatically did in these studies is anyone older than 55 or have siblings older than 55, they were excluded from the donor arm. So they were basically randomized to the non-transplant arm without giving them even a chance to be randomized to the transplant arm. The other thing regarding the analysis is for most of these clinical trials, the analysis was done based on what arm the patient was allocated to, not what type of treatment the patient actually got. So a patient with a donor was analyzed as if they got a transplant. But we know that some patients with donors, they never achieved remission or they got severe toxicity with the treatment and never got their transplant. And so those patients make the transplant arm actually look worse than it actually is. On the other hand, some of the patients allocated to the non-transplant arm, because they didn't have match-related donor, ended up getting transplant from alternative donor sources. For example, a haplotransplant or a match-unrelated donor transplant. And so those patients made the non-transplant arm actually look better than it actually is. And so all of these kind of factors explain why we have so much inconsistency across data, and it's very difficult to get into like any actual conclusions. And so one way to overcome that is there's the American Society of Transplant and Clinical and Cellular Therapy. It's the governing body of all transplant practices within the United States. What they do is that every few years they actually meet together and try to come up with recommendations regarding which patients should or should not undergo transplant for all diseases. So what is their stand regarding transplant in ALL? And we're talking about Philadelphia negative ALL. So should allo BMT be offered to a patient standard risk ALL? The answer with available data that is unclear. We do not know if these patients will benefit or will not have additional benefit from transplant. So what we do is we usually have our patients part of the decision. We counsel them that you might not have that much benefit with transplant in your first remission. You might never have a relapse. However, if they do have a relapse, what data looks like is that they actually do have the same benefit from transplant done in second remission. The problem is if the patient do relapse, it's very hard to get them into a second remission. So we let patients be part of that decision. Second question, should allo BMT be offered to adults with high-risk ALL? The answer is yes. So everyone with high-risk disease should be offered transplant in first remission. Should transplant be offered to patients in CR2? Meaning if a patient develops a relapse. What we think right now is that with available data, anyone who has a relapse should undergo transplant in their second remission. The oral or induction chemotherapies are not enough to cure a patient after their relapse. Transplant is the only hope for a cure. The last question, should allo BMT be considered for refractory ALL? And the answer is it's unclear. So a patient gets induction chemotherapy, they never achieve a remission, they have no further lines of therapy to induce this remission. Would you take them to transplant in active disease? The answer is we don't know. Again, the patient is part of making that decision. So take-home message, all patients with ALL need to be referred to a BMT service for discussion of transplant. Whether or not they actually go to transplant, that is, the patient has to be part of our decision, part of the discussion, and help us make that decision for them. Thank you.
Next speaker from Jordan, from King Hussein Cancer Center. It's a virtual presentation. Welcome to Dr. Muhammad Maakouche. His speaks is about update in Hodgkin lymphoma.
السلام عليكم.
وعليكم السلام. تفضل.
Can you hear me?
احنا سامعينك بس مش شايفينك.
أنا آسف. مساء الخير جميعاً. I'm very happy to join you. All participants. Can I share my slides or you will?
Not yet. Slides not seen.
Most disabled participants. Sharing. It looks I cannot share my slides. It's being disabled by the host.
Dr. Muhammad, now our technical team working with you, they will try to solve the problem.
Okay, thank you, Dr. Hassan.
دكتور بتقدر تشارك هسه.
اوكي. لسه بعطيني والله host disabled participant screen sharing.
Doctor, try again, please.
Okay. I'm getting the same message صراحة.
Already shared. You can start, dear Muhammad.
Okay, thank you. Today I will talk about the new treatment approaches in frontline treatment of Hodgkin lymphoma. Hodgkin lymphoma is the most common subtype of lymphoma in Jordan, accounting for about 40% of cases Next, please. And it does not follow the classic bimodal age distribution that is being described in literature. And this is most probably related to the lower incidence of mixed celerity and lymphocyte depleted subtypes. Next, please. And as you know, the current standard of care for early stage Hodgkin lymphoma that we classify the patients according to different laboratory and the clinical features to favorable or unfavorable groups, and we treat those patients with favorable early stage Hodgkin lymphoma with 2 cycles of ABVD followed by involved site radiotherapy, while unfavorable group are being treated with 4 to 6 cycles of ABVD followed by involved site radiotherapy. For advanced stage disease, the most commonly used regimen is ABVD, though some centers in Europe and even North America, they are using dose-escalated BIACOB. But it is not widely adopted because of fears of acute and long-term toxicities, though most of the studies show that it results in improvement of progression-free survival. Next, please. Why new treatment strategies are needed in Hodgkin lymphoma? Because we aim to reduce treatment-related morbidities without increasing the risk of relapse. And in a recent paper that examined the long-term toxicities of ABVD, even with the newer radiotherapy techniques, there was a higher risk of secondary malignancy and increased risk of cardiovascular disease and higher risk of respiratory disease in survivors of Hodgkin lymphoma. In addition, the new treatment strategies aim to improve outcomes in patients older than 60 years. Next, please. 2 main strategies are used to improve the outcome in Hodgkin lymphoma. The first is the bit data approach, and this helps in selection of patients that we do an interim PET scan mostly after the 2nd cycle of treatment, and we individualize our treatment approach based on the result of the PET CT scan. For patients having a good response after PET CT scan, we may de-escalate the treatment, and for those patients having a persistent or unfavorable response to PET CT scan, we tend to escalate the treatment. The second approach is the use of novel agents, and the most important novel agents being used in Hodgkin lymphoma is the PD-L1 inhibitors and the brentuximab vedotin, that is the anti-CD30 monoclonal antibody drug conjugate. Next, please. What's new in early stage Hodgkin lymphoma? Most of the trials are aiming to eliminate radiotherapy. The first one is the RAPID trial, and it included patients with early stage Hodgkin lymphoma, includes both favorable and unfavorable, and those patients having, all patients had 3 ABVD, and those patients having BIT negative ABVD, they were randomized to either no further treatment or involved field radiotherapy. And after a median follow-up of 60 months, the RAPID trial showed that in the intention to treat population or the per protocol population, the arm that was randomized to no radiotherapy had a borderline significant decrease in progression-free survival. And the trial actually did not meet its primary endpoint. Next, please. Another trial that studied the elimination of radiotherapy after ABVD, the H10 trial, and that was a trial that involved also a favorable and unfavorable group of early stage Hodgkin lymphoma patients. And these patients were either randomized to the standard treatment with either 3 or 4 cycles of ABVD followed by involved node radiotherapy, regardless of the interim PET CT scan result. And the study arm was included the individualized treatment based on the PET CT scan for a total of 4 cycles of ABVD for BIT negative patients in favorable and 6 cycles of ABVD in the BIT negative unfavorable state, Hodgkin lymphoma. And actually, the results came that the favorable group did much worse than the standard, and with a progression-free survival in the standard treatment group of 99% versus 87% in patients who did not receive radiotherapy. And even in the unfavorable group, there was a statistically significant inferior outcome in the patients randomized to no radiotherapy. While in BIT positive patients, the outcome was better in those patients who received those escalated BIACOB. Next, please. That was the part of early stage Hodgkin lymphoma treated with ABVD. What about those escalated BIACOB? HD14 established that 2 doses of those escalated BIACOB followed by 2 doses of ABVD may be the preferred treatment, upfront treatment for early stage unfavorable Hodgkin lymphoma. Based on these results, patients were randomized either to a BIT adapted approach, so that patients with BIT negative after 2+2 received no radiotherapy, while the other standard arm received involved feed radiotherapy. Next, please. And actually, this is the first trial that there was no difference in progression-free survival when patients treated with chemotherapy only, and based on the PET CT scan, radiotherapy was omitted. There was no significant difference in progression-free survival and overall survival. Next, please. What about the use of brentuximab in the upfront treatment in patients with early stage Hodgkin lymphoma? Actually, that was a trial that combined brentuximab vedotin with 2 cycles of AVD, and those patients had another 2 cycles. An interim BIT was done after 2 and 4 cycles. Actually, the treatment was changed based on the BIT 4 result. And if the patient is having a positive BIT scan or had a negative, if they had a positive BIT scan, they had a biopsy. If the biopsy is positive, they went off study. While those patients having a negative BIT scan or had a negative biopsy, they were again randomized to 4 treatment radiotherapy approaches, either no radiotherapy or the standard treatment with 20 grays or 30 grays, or another conventional radiotherapy field that was the consolidation volume radiotherapy. Next, please. And there was no any statistically significant difference in the progression-free survival between the 4 treatment groups, either radiotherapy were omitted or radiotherapy was continued. Next, please. What about the use of nivolumab? It was a small trial, included 109 patients with unfavorable early stage Hodgkin lymphoma. Actually, it did not test omission of radiotherapy, but it tested 2 approaches for treatment of these patients, either the concomitant approach with giving nivolumab in combination with AVD, followed by radiotherapy, or a sequential approach of giving 4 cycles of nivolumab, followed by 2 cycles of nivolumab with AVD, and followed by 2 AVD, followed by radiotherapy. Next, please. And you see here the complete response rate after either the sequential or the concomitant approach. In the sequential approach, worth mentioning that about 45% of patients achieved a complete metabolic response after only single agent nivolumab. But while in the concomitant approach, about 85% of patients achieved complete remission after the first two cycles. As you see, by the end of treatment, all of the patients in the concomitant approach were having a disease, and most of them were in remission. Next, please. A median follow-up of 13 or 14 months, actually, the results were impressive with a estimated progression-free survival rates of 198%. And these results are encouraging for inclusion of nivolumab and immune checkpoint inhibitors in the future prospective trials. Next, please. What about the advanced stage disease? you know that the RATHIL trial was the first to examine omission of bleomycin after BIT2 negative in advanced stage Hodgkin lymphoma. And there was about 1.6% difference in the progression-free survival in those patients who had omission of bleomycin after a BIT2 negative disease. However, the follow-up of the RATHIL trial was about only 3 years, and the trial was not confirmed by another trial. Next, please. The other trial that examined the BIT adaptive approach in patients with advanced stage Hodgkin lymphoma, two cycles of ABVD, in the SWOG trial, 2 cycles of ABVD, and after BIT negative continued with ABVD, BIT positive, they went to dose escalated BIACOB, and after a median follow-up of about 6 years, yes, you see here that about 1/4 of patients who had a BIT negative disease and continued with ABVD, they had a relapse. While the overall survival was good, it was about 94%. Next, please. So, what about the use of the BIT adapted approach in patients treated with frontline dose escalated BIACOB? Those patients who had an advanced stage Hodgkin lymphoma received 2 dose escalated BIACOB, and BIT CT scan was done. For patients with a negative BIT CT scan, they received only 2 cycles, so that total of 4 cycles with escalated BIACOB, while the standard is to give 4 to 6 cycles dose escalated BIACOB. In the BIT positive patients, they tested addition of rituximab to the standard dose escalated BIACOB. Next, please. And as you see here, there was no statistically significant difference in BIT2 negative patients treated with 4 dose escalated BIACOB versus 6 to 8 dose escalated BIACOB, either in progression-free survival and overall survival. And based on this trial, you can say that 4 cycles of dose escalated BIACOB is enough for patients with BIT2 negative disease. Next, please. What about BIT2 positive addition of rituximab did not add to the progression-free survival or overall survival to dose escalated BIACOB? Okay. Here there was another trial that tested the addition of the dose escalated BIACOB, and the standard arm was to continue dose escalated BIACOB, while the test arm was to de-escalate to 4 cycles of ABVD in those patients having a BIT negative disease. Again, there was no statistically significant difference in progression-free survival or overall survival between the 2 treatment groups. Based on this, you can say that after 2 escalated BIACOB, BIT negative, you can continue with ABVD if BIT CT scan continues to be negative. What about in KCC, in a study that was did by Dr. Akram Ibrahim from the nuclear medicine, examined the value of BIT CT scan after 2 or 4 cycles of ABVD, and we found there was no difference in the predictive value of doing a BIT CT scan after 2 or 4 cycles, and both showed highly significant difference in event-free survival. Worth mentioning that in our study, the difference between the difference between the complete metabolic response rate at BIT2 and BIT4 was only 3.5%, so that 96.5% who had a complete metabolic response at the interim BIT scan, they had a complete metabolic response on BIT CT scan by the end of treatment. Next, please. Brentuximab vedotin use in advanced stage Hodgkin lymphoma, as you know, the trial was recently updated in the ASCO and published in the New England Journal of Medicine. And this trial included more than 1,300 patients, and were randomized to either 6 cycles brentuximab with ABD versus 6 cycles of ABVD. And after a median follow-up of 6 years, there was a statistically significant difference in progression-free survival as well as overall survival. And this is one of the few trials that showed the difference in overall survival in patients with advanced stage Hodgkin lymphoma. And as you know, the concern of peripheral neuropathy was more common in patients treated with brentuximab, but most of these patients had resolved with the continued follow-up, although the median time to resolution was 16 weeks in brentuximab arm versus 10 weeks in ABVD arm. Next, please. However, in editorial for this trial, we have to mention that there was imbalance, and this is from second cancer. You see here that in patients with ABVD, 11 patients died from second cancer versus 1 patient who died from in the brentuximab arm, though only 3 patients in the ABVD arm and 2 in the brentuximab arm went to transplant or had myelodysplastic syndrome. The other thing is that there was imbalance in the pulmonary toxic effects. 11 patients in the ABVD group were compared with none in the brentuximab group. And the study protocol did not specify how patients who had pulmonary symptoms were treated or followed. And the cost effectiveness, according to this editorial, 6 cycles of brentuximab with ABVD will cost about $275,000 accordingly. So a cost effectiveness trial was done, yes, next please, and was presented in the last ASCO conference and showed that if brentuximab ABD to be cost effective, there should be reduction in the cost by 56 to 73%, so that it would be cost effective in the United States, where the acceptable cost effectiveness in $150,000 to $100,000 per quali. For example, in the UK, it is 200 to 300 UK pounds. In KHC, it's about 42 to 56,000 per year dollars per quali. So I think the cost should be reduced significantly before adopting this regimen, although it is very effective. Next, please. What about the use of pembrolizumab? Pembrolizumab is used in a small trial, and it used a sequential approach, actually, with 3 cycles of brentuximab followed by 4 to 6 cycles of AVD. Okay. And you see here that by the end of treatment, all of those patients had a complete metabolic response, and a median of follow-up of 22.5 months. All of these patients were progression-free. Next, please. Nivolumab also was tested in advanced stage in combination with chemotherapy, with a sequential approach of giving 4 doses of nivolumab followed by 12 doses of nivolumab with AVD. And as you see here, there was impressive responses, and after 9 months of follow-up, 92% of patients were progression-free. Next, please. This is an ongoing trial that will answer our question if combination of immune checkpoint inhibitors with AVD versus brentuximab with AVD is better. Next, please. What about the older patients? We'll go over very quickly over this. You know, the pathology, the pathobiology of the disease in older patients in Hodgkin lymphoma is different. They present with more aggressive features, and they have more treatment-related toxicities. About 20 to 30% of patients will have bleomycin toxicity, and death is in about 25%, and it is associated with more treatment delays and suboptimal dosing. An analysis of equivalent trial that tested brentuximab AVD versus ABVD found there was no benefit of brentuximab AVD in comparison to ABVD in patients older than 60 years, even though toxicities were more common. The most attractive approach in older patients, because they maybe have suboptimal performance status, is to use the sequential approach, so that you control the disease with minimal toxicity with brentuximab. You add 6 cycles of AVD, and you consolidate with 4 cycles of brentuximab for responding patients. And as you see here, that the median progression, 2-year progression.
Remaining 2 minutes, please. Time. 2 minutes.
2-year progression-free survival was 84%, and 2-year overall survival is 93%, and this is the highest numbers in this subgroup of patients. Next, please. Another trial tested brentuximab alone in combination with chemotherapy, either with dacarbazine, bendamustine, and or nivolumab. And as you see here, that the responses and the progression-free survival were impressive. However, in the arm where brentuximab was combined with bendamustine, it was closed early because of multiple acute toxicities. Next, please. Brentuximab nivolumab was also tested in another trial, but it was closed early because it did not meet the primary endpoint of a response rate of 70%. Next, please. Okay. So in conclusion, patients with early stage disease, favorable 2 cycles of ABVD followed by radiotherapy. Radiotherapy can be safely omitted after 2+2 protocol, and incorporation of brentuximab with immune checkpoint inhibitor in the frontline treatment is promising. Next, please. For advanced stage disease, omission of bleomycin can be safely considered in patients with ABVD having complete metabolic response after 2 cycles, while those patients having complete metabolic response after 2 cycles of dose-escalated BIACOB, they can either continue with 4 cycles of ABVD or 2 cycles of dose-escalated BIACOB. Next, please. And patients with older patients, management is challenging. Brentuximab with ABD may result in good disease control as a sequential approach. And for frail patients, brentuximab with DTIC may be reasonable. And thank you.
Thank you, Dr. Muhammad, for your interesting talk. Now it's again our pleasure to present to you Dr. Muhammad Sami Al-Qatari. He is a consultant, hematologist, and assistant professor at Thunder Bay Regional Center Care, Ontario, Canada. Please take the stand. Sorry, his talk is going to be about updates on the front line of management of chronic lymphatic leukemia.
Yeah, it's been a great pleasure to be here today with you. I'm really excited to be here for the first time in my life. I'm from this land. So thank you very much, Dr. Barkawi and organizing committee for having me today and allowing me to participate in this distinguished meeting. As you see here, this is my topic. So I'm going to talk about the updates on the frontline management therapies in CLL. How can I move this slide? Yeah, this is my disclosure. Like I got nothing to disclose. Shukran. So back to the... Okay, yeah. أيوه أوكي. أوكي خلاص. شكرا. As you know, like RAI and BINET classifications have been widely used for clinical staging of CLL. They are simple, easy to use. Yeah, they are simple and easy to use. And they categorize patients into three groups, as you know, the low, intermediate, and high risk. However, with the recent advances in CLL therapies and the discovery of the new genetic mutations over the last decade or so, these staging systems, they become like not sufficient anymore. CLL International Prognostic Index has been the current relevant prognostic scoring system using 5 independent prognostic factors: 17p deletion or TP53, IGHV mutational status, serum beta-2 microglobulin, clinical staging at age. And as you know, like patients with CLL, whenever they're diagnosed, they should be monitored as long as they're asymptomatic, and once they become symptomatic with active disease, progressive disease, according to the international workshop criteria, which has remained the same, not changed, they need to be considered for treatment. Like around or approximately 80% of CLL patients, they have at least one mutation or one chromosomal abnormality. The deletion 13q is most commonly seen in CLL patients, around 55%, and as you know, it carries a good prognosis, while 17p deletions is seen around like 5 to 8% of the cases, and usually associated with a poor prognosis and worse survival, and that's because of the loss of the prominent tumor suppressor gene, which is located on the short arm of 17p chromosome. 17 or 11q deletion, it's another bad chromosome, usually carries a worse prognosis in CLL patients, and usually the CLL patients with this deletion, they usually or typically progress fast with lymphadenopathy, and they have a reduced survival. TP53 mutation is also another one of the worst gene mutations seen in CLL patients in around 4 to 37% of the cases. And again, it's been associated with very bad prognosis and reduced survival, and that's been, I think, witnessed in even other type of cancers, hematologic malignancies. IGHV mutational status, the unmutated one, is being also associated with a poor prognosis as compared to the mutated IGHV. Now, due to the recent advances in the CLL therapies and the discovery of the genetic mutations, our understanding on CLL has expanded, in fact, allowing us to understand more about the disease behavior, progression, and the discovery of new drive mutations and subsequently new targeted or novel agents. So as you see here, the landscape, the therapeutic landscape of CLL, like over the last decade, has evolved significantly, moving from the classical cytotoxic chemotherapy agents, mainly FCR, which has been the standard for the measurement of CLL for a long time, until the new agents, the monoclonal agents, such as obinutuzumab, has been discovered in 2013, and then the new agents, the novel agents, apretinib, it's been approved between 2013 and 14. After that, the BCL2 inhibitors, venetoclax, approved in 2016, and then lastly, the acalabrutinib, which has been approved in 2019. And now we do have also the zanopretinib, which is approved already for other indications, the mantle cell lymphoma, Waldenström macroglobulinemia, and marginal zone lymphoma, and now it's been also accepted for consideration of approval by FDA next month in October 2022. In order to understand like how these novel agents they work, we need to understand like how the CLL cell looks like. And as we see here, the B cell receptor on the CLL cells usually is supported by different tyrosine kinase BTK inhibitor, spleen tyrosine kinase, and P13K. The inhibition of these receptors made a revolution like in the management of CLL, especially when it's combined with other monoclonal agents such as obinutuzumab. The BCL2 protein, as we know, which is the protein which regulates the cell death or apoptosis, and the inhibition of this protein also made an excellent outcome in the management of CLL cases, either like as a single agent or even when it's combined with other monoclonal agents, obinutuzumab, or even with BTK inhibitor most recently. These are the available therapies for CLL. As we know, like the chemotherapy or the chemoimmunotherapy regimens, FCR for fit CLL patients, fit less than 65-year-old, still used. The BR and the obinutuzumab chlorambucil also has been also, like both protocols, have still been used, and all of them used still only in the mutated IGHV status, without 17p deletion, without TP53 mutation, and without other high-risk features. As we know and we learn from the literature that they don't do really well with these mutations. And as we see here, the BTK inhibitors, whether aprotinib or acalabrutinib, or in the future zanaprotinib, also like have been approved like as an excellent treatment for CLL, whether as a single agent indefinitely or when combined with other monoclonal agents. And the BCL2 inhibitors, venetoclax, also as we talked about it just shortly, has also been approved as a treatment, as a first-line therapy for CLL patients, and usually given for a limited period of time. The P13K inhibitors, they are not being used as a first-line therapy, and usually preserved for the second or like for refractory cases. There are numerous number of phase 3 randomized clinical trials which demonstrated the efficacy of these novel agents as compared to the chemoimmunotherapy protocols or regimens. In the first two trials, the FLAIR and the ECOG or E1912, they compared these, the aprotinib with the standard FCR in fit patients below 70 or below 65-year-old. And in the following studies, they compared bendamustine rituximab, which is being given for less fit patients with comorbidities. Also, they compared it with other BTK inhibitors, aprotinib in Alliance and zanaprotinib in Sequoia. And also, the other regimen like the obinutuzumab with chlorambucil has been also compared with other agents in less fit patients. In general, all these trials have demonstrated a superior efficacy and tolerable profile with novel agents as compared to chemoimmunotherapy regimens, and in the high-risk patients, 17p deletions, TP53, and patients with multiple comorbidities. Here, I'm going to go over just a few of these trials very briefly. In the ECOG, which is very recently published, ECOG 1912 trial, which has been recently published in July 2022, after a median follow-up of almost 6 years, the investigators they randomized patients less than 70-year-old fit patients with no comorbidities to either FCR or aprotinib and rituximab. And as we just said, like the progression-free survival has been proven to be way higher in those patients who received the aprotinib rituximab regimen as compared to the FCR. Interestingly, in this study, the PFS has been shown like to be superior and not only the unmutated IGHVs, also in the mutated IGHV, unlike most of the CLL trials which showed only benefit in the unmutated IGHV. So in terms of overall survival, it's also, there was no, to be honest, there was a small but it was statistically significant difference between the Epidemiology, rituximab arm as compared to the FCR. And that was mainly because of the unmutated IGHV, not really because of the mutated IGHV. In terms of safety, as we know, like more cytopenias have been observed with FCR, more infections have been also observed with FCR. On the other side, with a protonib arm, more risk of high blood pressure, atrial fibrillation, cardiac arrhythmias. And also here, in terms of the secondary malignancies, it's been reported that more secondary malignancies have been observed in the patients who received a protonib rituximab arm. However, that was not really statistically significant and was not really consistent even with other trials which did not really report the same increased secondary malignancies in patients who received BTK inhibitors. In Alliance trial, which is another phase 3 randomized controlled trial, they randomized also again, in this trial they randomized less fit patients who are above 65-year-old with some other comorbidities, renal impairment, some other reduced functional status, and they randomized them to 3 arms, either a protonib with rituximab, or bendamustine rituximab. And again, the same observation, the PFS was reported to be higher in patients who received protonib-based therapies, either as a single agent or combined with the rituximab as compared to the PR. So they have achieved a better result. However, the addition of rituximab in this trial, it didn't seem that it do a lot, because there was no really big difference between patients who receive a protonib alone as a single agent or a protonib combined with a protonib. In terms of overall survival, there was no really a big difference between the 3 arms. And if we again subgroup, analyze the subgroup analysis, the mutated, again, it was obviously the PFS was significantly higher in the patients who received bendamustine rituximab, in the patients who received a protonib rituximab as compared to those who received the bendamustine, and that was observed mainly in the unmutated, while in the mutated there was no really big difference, which is probably also consistent with other trials. And again, here, the PFS was also superior in patients who received a protonib for patients with 17p deletion, while it was way lower in patients who received bendamustine rituximab in the green line, as you see. This is the CLL14 trial, which is also presented in last EHA. And again, another randomized phase 3 randomized trial. They again included patients with comorbidities, and they randomized them to venetoclax combined with obinutuzumab or chlorambucil combined with obinutuzumab. I mean, here, both venetoclax and chlorambucil given for 12 cycles over 1 year, while obinutuzumab in both arms given just only for 6 cycles. And again, it was obviously, there was a significant superior progression-free survival in those patients who received venetoclax with obinutuzumab as compared to the chlorambucil obinutuzumab arm. And as we see here, that the median progression-free survival, it was around 36 months in those patients with chlorambucil obinutuzumab, and while on the other arm, the venetoclax obinutuzumab, it was not even reached. It means that the majority of the patients who received venetoclax obinutuzumab for 1 year, they remained off treatment for 3 years, and they're still in remission with no disease progression, which is excellent.
Dr. Muhammad, 1 minute to conclude your talk, please.
Yeah, I'll try to finish quickly. It took me 1 day until I come here. And again, the same thing in terms of, the high risk features, the IGHV mutations and TP53, and regardless of these, new mutations, a superior PFS has been observed in patients who received venetoclax-based therapy. In terms of safety, there was no really big difference. This is just the how to approach, moving forward, how to approach patients with CLL who need a treatment. Initially, we need to assess the TP53 status by next generation sequencing and 17p deletion by FISH study. And if they have these mutations, then patients, they will consider mainly for novel agents, Aprotinib or Acalabrutinib, whether as a single agent or combined with monoclonal agents, or BCL2 inhibitors, venetoclax. Well, if they don't have these 17p deletion mutation or 17p deletion or TP53, then we need to determine their IGVH status. So if they have unmutated IGHVC, then again, similar to what we did with the 17p deletion TP53, novel agents with or without monoclonal anti-CD20 monoclonal agents or BCL2 inhibitor. While on the IGVHD mutation, also, you need to assess the fitness, and if the patients are fit, healthy, then again, you still can use the other novel agents, but here you can use the FCR. While if they are unfit or they have more comorbidities, then again, you can still use the target agents, novel agents, but here you use the less toxic regimens like BR or clonopacide and bevacizumab. If you allow me just to present the last two slides. Now, which one to pick, which one to choose? I mean, it's hard. Now, there are several considerations you need to keep in mind before you know like which one to choose. Now, the BTK inhibitor, which is an oral treatment, as we know, is given indefinitely, is usually logistically easy to start. It's just you write your script, and next day patients will start. While on the BCL2 inhibitor like venetoclax, the initiation is a bit bothersome because patients, they will require special care initially when they receive the ramp-up dosing because of the increased risk of the tumor lysis syndrome and because of the GI toxicity which can happen. So they may require admission. It depends on the facility and the protocol for this. Now, also, there are some other considerations also one needs to keep in mind before they choose their which treatment to be given. If the patient has a history of cardiac arrhythmias, atrial fibrillation, anticoagulation therapy, or they have a blood pressure which is like difficult to control, then probably you may consider acalabrutinib or venetoclax over aprotinib. While if the patients they have a renal impairment, or they have high risk tumor burden, and they are at higher risk for tumor lysis syndrome, then probably consider aprotinib or acalabrutinib before venetoclax because of the associated risk of tumor lysis syndrome, which can happen with venetoclax. And the last thing here, which is very important, patient's preference. People need to be considered what they want. They want to just have some indefinite treatment for a long time, or they want to have a limited, like a treatment for a limited period of time. And I think probably you might also agree with me, like funding and hospital resources might play the main role, like for which treatment to give. I do have the slides, but I'm going to stop here.
Thank you very much, Dr. Muhammad. Our next and last speaker, we invite Dr. Razan Alfar. She is our, it will be Zoom recording. Razan Alfar is a consultant medical oncologist, myeloma, leukemia, and bone marrow transplantation from King Hussein Cancer Center. She will speak about triple therapy for refractory multiple myeloma.
Assalamu alaikum. I will talk today about the updates in the anti-BCMA in relapsed refractory multiple myeloma. I chose this talk because the outcome of those patients who failed, who are triple refractory multiple myeloma are really dismal. And this showed in the Mammoth trial, that is a retrospective multi-center trial, including about 16 centers. It showed that the overall response rate in triple refractory patients less than 30, about 30%, and in penta-refractory patients less than 30%, with a median progression-free survival of 3 months and median overall survival of 9 months for triple refractory patients, and even about 5 months for patients who are penta-refractory. What's approved for anti-BCMA? Currently, belantamab, the first one approved, that's the antibody drug conjugate that we'll talk about. And the first CAR T cell is the ide-cel that's also approved, showed the response rate of about 70 to 80% with a median progression-free survival of 8.8 months, and the updated median overall survival about 25 months. And also cilta-cel also was approved as another CAR T cell. And a few days ago, the EMA approved the teclistamab, that's one of the bispecific T cell engager. I will start talking about the antibody drug conjugate, belantamab, that was approved according to the DREAM2 study, with the last follow-up for this study that's presented in the ASCO 22, showed with dose of 2.5 milligram per kg, Q3 weeks, an overall response rate of about 32% with a VGPR about 20%, and the median duration of response of 11 months. And but the main side effects of this drug is ocular toxicity, which is the keratopathy. So the grade 3 or more toxicity, about 50% of those patients had grade 3 or more toxicity with blurry vision in about 4%, but all were reversible. So in order to decrease the toxicity and increase the effect of belantamab, we have to either use less frequent doses or to combine it with another agent. So how can we improve this? Either by, as we said, by lowering the dose or increase the interval between the doses. And we can increase the response by use it in combination, lead to a less interruption, and also we can use it as an earlier line of treatment, as we will see in the next coming slides. So in DREAM4 trial, they combined the belantamab with pembrolizumab, as one of the mechanisms of resistance to anti-BCMA is the overexpression of PD-1 and PD-L1, so led to less activation of the T cell and less tumor killing. So if we block this receptor, we can increase the tumor killing by belantamab. So they combined belantamab with pembrolizumab in the DREAM4 study, and the recommended phase 2 dose was 2.5 milligram IV Q3 weeks regarding belantamab, and pembrolizumab 200 milligram IV Q3 weeks. It showed minimal improvement in the overall response rate. It's only was 43% in comparison to about 30 or 35% in belantamab alone, and the VGPR was 25% in comparison to about 20% in belantamab alone. Regarding the toxicity, and also the median duration of response was not so much increased in combination with pembrolizumab. Regarding the toxicity, the ocular toxicity increased with the combination, and the keratopathy was about 71%, and the grade 3 or more was about 68%. So this combination led to very minimal improvement in the overall response rate and to higher toxicity in addition to the autoimmune toxicity related to pembrolizumab. So they try to combine gamma secretase inhibitor with the belantamab, as gamma secretase cleaves the membrane-bound BCMA, releasing the soluble BCMA into the circulation, which interfere with the anti-BCMA directed therapy. So in the preclinical data, it showed that in rogasitat, which is the gamma secretase inhibitor, increased the cell surface level of BCMA and reduced the soluble BCMA. So in the DREAM5 study, they combined the nigarositat with the belantamab, and you can notice here that they used the lower dose of belantamab, 0.95 milligram per kg Q3 weeks, with gamma secretase inhibitor, 100 milligram twice daily, and it showed almost the same response with belantamab alone, but significantly lower ocular toxicity with grade 3 or more of about 12.5%. So we can use this combination and add another agent that is the immune modulator, as we will see later on in addition with the pomalidomide. Regarding the DREAM6 trial, they tried to combine lenalidomide with belantamab, as lenalidomide is an immune modulator, and this may enhance the effect of belantamab by accelerate the efficacy of T cell and NK cell killing. So in this trial, they combined the standard dose of 25 milligram lenalidomide and dexamethasone 40 milligram Q week with belantamab of different schedules and different doses. And they noticed that with the dose of 1.9, that is less than they recommended the dose in the DREAM2 study, 1.9 milligram per kg Q4 weeks showed an overall response rate of 75% and the VGPR of about 50%, and the keratopathy grade 3 or more was only 25%. But in the clinical in the real life, most of our patients are len exposed or len refractory, so they try to combine belantamab with pomalidomide and also using the gamma secretase inhibitor, and we'll see the data of this trial that's still ongoing. Now, regarding the CAR T cell, as we said, the ida cell is the first one approved for patients who received 4-line and they are triple refractory. And but with the ida cell at 3 months, they showed that most of the patients they lost the expression of the CAR in their T cells. So they tried to modify the manufacture of the CAR T cell by using the CELTA cell that is bind with two BCMA targeting single domain antibodies in order to increase the persistence of the CAR T cell. And we'll present here the updated data in the ASCO 22 with a median follow-up of about 2 years. So after the preparation of the CAR T cell and lymphodepletion using the Cy/Flu, and you can notice here that the dose of CELTA cell is much less than the IDA cell. It's only 0.75 million. Then most of these patients were heavily pretreated, and they received the median of about 6 lines. And with a follow-up of about 2 years, we'll see their outcome. The baseline characteristic of those patients also include the patients with high burden disease, like the presence of extramedullary disease, the bone marrow with more than 60% involvement, and the high-risk cytogenetics. And as we said, the median line, previous line were 6, and also most of patients were triple refractory, and about 40% of them were penta refractory. It showed that with the longer follow-up, the overall response rate was about 98%, with the VGPR about 95%, and the stringency CR increased from 60% with the initial data to 82.5%. And all of patients, regardless of their baseline characteristic, responded, but the median duration of response and the progression-free survival and overall survival was shorter for patients with high burden, with high tumor burden and ISS stage 3 and high-risk cytogenetics. And also, the median persistence of the CAR T cell about 6 months. So it is longer than what was seen in the IDA cell, which was less than 3 months. Regarding the persistence of MRD negativity, it showed that about 40% of them persistent MRD negativity at 6 months, and about 20% of them more than 12 months, with a median progression-free survival of those patients with persistent MRD negativity of more than 6 months, about 91%, and about 100% in patients who remained MRD negative at 12 months. At the last follow-up of this trial, the median overall survival was not reached. Regarding the safety profile, with a longer follow-up, no more death from CAR T cell, and the main side effects, as we know, are the CRS, and most of them were manageable, and the grade 3 was less than 10%, and also the neurological toxicity, also most of them were manageable with less than 10% of a grade 3 or more. So with further follow-up of the CARTITUDE trial, it showed significantly improved response rate and progression-free survival and overall survival. This gives the hint to using cilta-cel as an earlier line of treatment in patients who receive 1 to 3 lines of treatment, and in patients who are even in the frontline setting in the transplant eligible and transplant ineligible trial, and we'll see the data for those trial later on. Regarding the BiTEs, that's the bispecific T-cell engager, teclistamab was recently EMA approved about a few days ago according to the Majestic-1 trial. This drug is off-the-shelf, fully humanized IgG4 BCMA CD3 bispecific antibody. It redirects the CD3 T-cell to mediate T-cell activation and subsequent lysis of the BCMA expressing myeloma cell. The recommended phase 2 dose from the teclistamab Majestic-1 trial was 1.5 milligram per kg subcutaneously Q week. And after the two setup doses of 0.06 and 0.3 milligram per kg 2 to 4 days apart, and then the full dose was given
أنا للأسف الشديد disconnected المحاضرة فراح ننهي هون
2 to 4 days after the last dose.
Okay. Okay. We'll open the floor for questions. Any questions for the speakers? No questions. Okay, تفضل.
Thank you. So the data regarding the auto transplant in Palestine is very nicely presented. I wanted to ask about the duration of using Bactrim in your patients. So you use it for a full 1 year as prophylaxis post-transplant? Okay. So my question is, for example, we use for 6 months. We don't continue for a full year. But obviously that's different from one country to another depending on how frequently you see PJP infections.
I give half a dose, not the full dose, not the full dose Septrin or Bactrim. Just the 480 milligrams once every 2 days or every 3 days.
Okay. And the reason I'm asking, do you have any data in Palestine about the frequency of infections post-auto transplant? What the epidemiology of infections is? Maybe that can be cut down, the duration, if you don't see a lot of infections, or is that data difficult to collect with patients being from all over?
The problem is after 2 months of transplant, we lose the patients. They return back to their original treatment hospital, and we don't know much about them. But the risks of infection is very low after the initial 2 months of transplant.
Okay.
It's really very low.
And my second question, are you able to follow the patients post-transplant, for example, with day 100 workup, CT, PET scan, myeloma workup, anything to kind of assess which patients need further therapy?
Yes, if the patient is our patient, our center, we follow that up. But we send the recommendation letter with the patient to his treating physician, either in Gaza or different places, to follow him up with other CT scans or repeat bone marrow aspiration biopsies after such a period of time.
But my understanding, you don't have that data. They don't send the results back to
No,
you.
we don't. We don't have all of that, no.
Okay, thank you.
I have a comment, Sultan. Looking at the presentations, if we want to follow the guidelines as they come day by day. We will use all of our treatment will be monoclonal antibodies or targeted therapy treatment, and I'm sure we will not be able to treat our patients at that stage. All of those lines, TNIB, monoclonal antibodies, they're very expensive. They're very expensive. You're looking at the treatment for CLL. He nicely presented his lectures, excellent talk. But for us, it's not applicable. Honestly, I can't feel that we're going to use third and second, third and fourth and fifth generation of treatment lines for our patients. We're far away from there. I think if we stick to FCR, the standard treatment, compared to the best treatment, the overall survival is minimal. Let us stick to what we can offer our patients financially wise, money wise. Otherwise, we'll be treating one patient and not treating 10 others because of the money shortage. I don't know, not many people agree with me, but this is my opinion, honestly.
Hello. I agree with Dr. Riyad that it's nice to see all updates, but these medication very expensive. Yesterday we had a meeting in Ministry of Health. Very, very expensive medications. If we want to use the last updated protocols, I think within 1 month all money of the ministry will be used and the next patients will not continue. So it's nice to know the updates. When the medications price went down, it will be possible to use them maybe within 1, 2, 3 years, maybe. Some medications few years ago were 20,000 shekels and now 2,000 shekels. So it's nice to be updated for this.
If you allow me to make a comment about that, I'm just going to talk about KHC experience. I don't have figures, I don't have data with me right now. But we actually looked at survival of some of our patients. They're very comparable to the international numbers, even though all these medications we don't use either. Again, for the same reason. In the MENA area, these medications are very expensive and not readily available. But we still have survival outcomes comparable to the West. I'm guessing that Palestine is going to be the same thing. The reason most of these medications are being approved because of statistically significant benefit, but that does not translate into clinical benefit. Sometimes you have a 1% survival, but that's statistically significant, so the drugs get FDA approved. But that doesn't necessarily translate into a better outcome on the actual patients. And so yeah, I agree with you, wasting resources on a few patients and then not allowing a lot of other patients to be treated, it's very reasonable. That's why cost effectiveness analysis is very important in our areas before we approve very expensive medications and use them, again, on a few patients instead of treating a lot of them. Just a comment from our experience. It was not my session, so I apologize. But yes, I mean, cost-effective analysis is a very important part of cancer treatment in our parts of the world.
دكتورة سلوى دكتور سلطان.
يعطيك العافية دكتور سلوى. My question is about the transplants in ALL. You know, in the pediatric experience, Philadelphia ALL now very rarely indicated for BMT, especially in the complete MRD negative. My question is those with BHL-like adolescents or young adult, you investigated for more unfavorable cytogenetic like CRLF1 and other unfavorable cytogenetics, those with BH-like ALL and the outcome.
So for Philadelphia-like ALL, those are the patients that are Philadelphia chromosome negative. However, on the molecular level, they act and behave exactly like the Philadelphia chromosome positive. There's a lot of emerging data on that side. Using TKIs, anti-Philadelphia chromosome TKIs, is not still approved in that subgroup because the pathway, although they behave like Philadelphia chromosome positive, the pathway of activation is not always dependent on the same pathway that TKIs work on. With available data right now, we think that the problem with the Philadelphia-like is that it's very difficult to get them into MRD negative state. That's why everything we talk about comes back to the MRD negative state. Patients with Philadelphia chromosome positive or Philadelphia-like ALL, it's very difficult to get them into that MRD negative status. And that's why most of them end up needing transplant. And that's all retrospective analysis. There's not much prospective data, seeing if we add certain targeted therapies such as Jakafi, for example, for patients whose pathway is JAK dependent. But there is promising data that adding these targeted therapies might allow us to get into negative MRD early on, and so forgo transplant for some patients. Another point for the pediatric patients, and you asked about the pediatric patients, the induction therapy for pediatric patients is usually much more intensive than what we can give in adults. L-asparagine is a backbone of treatment for ALL in pediatrics. We give much lower doses in adults. And because it's very toxic, adults don't tolerate those high doses of asparaginase. And that's one reason why less percentage of our patients actually get into MRD negative status, less percentage of our patients actually achieve remission from first induction. And that's why we think that transplant in adults is still a backbone compared to pediatrics.
Thank you very much, Dr. Salwa, and everyone, speakers, and everyone attending. We conclude this session now, and the next session will be...
Okay, thank you very much. Thank you for this great Hemato-Oncology session. Thank you for our moderators, Dr. Hosni Maqbool, Dr. Hussam Salami, and Dr. Sultan. It was really nice talks from different parts of the world. I think we are not going to have a break because we need to proceed with the podium presentation and poster session at the same time. So I would like to invite Dr. Haytham Al-Hassan, Dr. Mohammed Luaym Bayed, Dr. Mohammed Abu Dhair, and Dr. Mohammed Haj Hamad, if he is here, in order to start the podium presentations. And I would like to remember that we have also a poster session, poster tour outside. If you go outside, if you want to look into the poster, you can have a thorough look and try to discuss the outcome of different poster presentations. We have around 11 posters, podium presentations. Each poster will have a separate evaluation from the 3 judges in order to choose the best poster for the prizes. And we will start in a minute. I will hand over the mic to Dr. Haytham.
Thank you. Welcome, everybody. In the next hour, we will present 11 posters. We will hear 11 posters, each 5 minutes. 3 minutes? It is hard 5 minutes, and we are making 3 minutes. Okay. To avoid losing time, the first presenter will be Dr. Khalid Al-Shawa. Dr. Khalid Al-Shawa is here. Yes. Dr. Khalid Al-Shawa is a senior surgical resident at Maqasid Hospital. He will present resection of primary renal leiomyosarcoma plus blah, 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 blah. Start, please. Don't waste time.
Resection of primary renal leiomyosarcoma involving the inferior vena cava with resection and reconstruction. Case report. Khalid Al-Shawa, Dr. Jamal Hijazi, Dr. Bashar Jaber, Dr. Haytham Al-Hassan, and Dr. Riyad Salah ad-Din, Dr. Omar Abu Zaid, and Dr. Riyad Haddad. Renal leiomyosarcoma is a rare and aggressive tumor. It arises from smooth muscles, cells of intrarenal blood vessels. It represents 1 to 2% of malignant kidney tumors. 50% of renal sarcomas are leiomyosarcoma. It has high tendency of local recurrence, so complete surgical resection is the only proven method that prolongs survival. Reconstruction of IVC is not always necessary, but is often required, especially when one or both kidneys is at risk, as in our case. We are reporting a 42 years old female patient. It presented with intermittent attacks of dull aching pain in right upper quadrant. On physical examination, it only had mild right upper quadrant tenderness. Imaging, including ultrasound, CT, and MRI, all showed heterogeneously enhanced soft tissue mass involving upper right kidney pole, measuring about 7 by 9 centimeters, involving liver, segment 7 and 8. It was abutting and invading the IVC. True cut biopsy showed leiomyosarcoma with many mitotic figures. As you can see, here we have CT cuts, axial and coronal. You can see the tumor is invading the right kidney and the liver. MDT discussion decided to go for surgery, intending for R0 resection. So intraoperative findings was there was a large solid retroperitoneal mass engulfing and invading the IVC from the level of left renal vein and up to the hepatic veins, compressing the right liver loop, segment 7. Resection, we did the right nephrectomy, IVC segment resection and reconstruction using 22 millimeter daconin graft, anastomose to the IVC at the level of left renal vein. As you can see, here is the edge of the liver. The right kidney was removed. You can see now the segment of the IVC removed and the graft at the level of the left renal vein. Why not pre-op embolization? Although evidence showed pre-op embolization induces pre-operative infarction and facilitates surgical intervention, that was not possible in our case for two reasons. There was no certain feeding vessel detected pre-operatively by imaging, and there was we were not sure if the origin of the tumor was renal or hepatic origin. Histopathology showed 9 centimeter leiomyosarcoma predominantly involving the right kidney and adrenal gland with negative ureteric margin. Tumor was limited by thin fibrous capsule superiorly. Invasive leiomyosarcoma of the kidney represents a technical challenge. Careful preoperative investigation and an experienced dedicated team consisting of vascular, urologic, and in our case was hepatobiliary surgeons are usually needed for safe, successful R0 resection despite extensive tumor involvement. Thank you.
Next abstract to be delivered by Dr. Rula Abu Wafa, Palestine.
Hello everyone, I am Rula Abu Wafa and I'm an intern at the Najah National University Hospital. Today I will talk about global scientific trends on partial nephrectomy research during 2000 and 2019, a biplyometric and visualized study. Okay, renal cell carcinoma incidence has been increasing over the last few years. In particular, small renal masses is the most common form of renal cell carcinoma. This is due to a widespread usage of different imaging modalities. The newly evolved concept of partial nephrectomy has shifted the surgical treatment from open surgery to minimally invasive surgery and from radical nephrectomy to partial nephrectomy. There are several published articles showing the superiority of partial nephrectomy in the prospect of better kidney function, which is one of the most important factors that helps to popularize partial nephrectomy worldwide. Also, there are several articles, systematic reviews, and editorials have been published since the concept of partial nephrectomy. However, the curve of annual published articles is steeply increasing, but is poorly correlated and not linked in a simplified graph or algorithm. So, the objective of this study is to use biplyometric methods to identify existing area of research activity in this field and to allow researchers to identify new areas of future growth. Okay, we use the Scopus database as the source of the data, and the VosViewer software was used to visualize the studies of partial nephrectomy in the past 20 years. The total number of publications was found to be 4,007. Most of these was journal articles with about 80%, followed by reviews and notes, then letters. Okay, as shown in this figure, which represents the number of publications on partial nephrectomy per year, there is a steadily increasing number of research in partial nephrectomy. As in 2000, there was less than 50 published articles, and in 2019, it reached about 350. Okay, this table shows the most 10 productive countries for partial nephrectomy research, with the USA being the most number of publications with about 1,647, followed by Italy and China. Okay, and this table shows the top 10 most productive institutions for partial nephrectomy research. The first one is Cleveland Clinic Foundation in the USA with about 331 publications. And here is the top 10 most productive journals for partial nephrectomy research with the Urology, Journal of Urology, followed by the Urology and Journal of Endourology with about 412. And this figure is representing the network visualization map for international research collaboration, and states that the USA and Italy represent the strongest research productivity and a collaboration between countries. So the strength and limitation of this study, it's the first bibliometric analysis in the field of nephron-sparing surgery to determine and visualize global productivity in this topic. And limitation, the database of this study only was Scopus, and there are certain keywords were missing in the research. Okay, so in conclusion, based on the Scopus database, the characteristic of nephron-sparing surgery research findings from 2000 and 2019 were analyzed using bibliometric and visualized analysis. The number of publications on nephron-sparing surgery has remained consistently high over the last 2 decades. Thank you.
And now with Dr. Sarah Shbeita, talking about global analysis of research trends of kidney function after nephron-sparing surgery.
So hello everybody, my name is Sarah Shbeita, I'm an intern doctor, and my research is about global analysis of research trend on kidney function after nephron-sparing surgery, a bibliometric and visualized study. We can start by saying that nephron-sparing surgery for small renal cell masses is currently the standard of care to treat renal cell cancers. This concept developed to preserve the kidney function, as there were many questions around about the nephron-sparing surgery and its effect. Okay. Starting by saying that several studies were comparing the oncological and functional outcome between the partial nephrectomy and the radical nephrectomy. It showed that there is equivalent oncological outcome, but still there is a questionable functional outcome. Furthermore, the surgically induced kidney injury are shown to have less adverse effect on long-term kidney function. The other debatable benefit is that nephron-sparing surgery decreased the cardiovascular diseases, secondarily to that nephron-sparing surgery, reducing the effect on long-term kidney function, and so decreasing the chronic kidney diseases, so theoretically improving the cardiovascular system outcome and increasing the overall survival. There's also another question that we're going around, is about the warm versus cold ischemia benefit on nephron-sparing surgery, but it showed that it's still not apparent whether the type of ischemia affects the long-term kidney function. Rather, there's the concept that is important on kidney function is that the duration of the ischemia and the quality of residual renal parenchyma. So we decided to do this research to answer these queries and to explore the research activities that has been undertaken since the early 21st century to investigate the advantages of nephron-sparing surgery on preserving the kidney function and preventing chronic kidney disease. Based on Scopius database, we use two steps. The first step that the term using in the Scopius engineering were extracted from the literature on nephron-sparing surgery. Then these researches were restricted to those with nephron-sparing surgery and kidney function on their term. The result was that a total of 449 scientific publications focused on renal function in nephron-sparing surgery between 2001 to 2020. The three most encountered themes were: the first one is the comparison between the radical and partial nephrectomy. The other one was about the type and duration of ischemia on the glomerular filtration rate decline, and the effect of different surgical approach on intermediate and long-term kidney function. Here we can see in this figure that the publication about nephron-sparing surgery and nephron-sparing surgery with kidney function were rising during the last 20 years. On this table, we can say that the top 10 most active countries in nephron-sparing surgery was topped by the United States. The top 10 most active journals were Journal of Urology, European Journals, Journal of Urology, and etc. Here in this figure, we can see the three themes that the publication were about. The red one was about the comparison between radical nephrectomy and partial nephrectomy. The blue one was about the duration and type of ischemia. And the green one was about the type of surgical approach. On discussion, the analysis showed that the research activities were about the three, mostly about the three topics we talked about. And the most important thing that the theoretical advantage of preserving kidney function in nephron-sparing surgery didn't improve overall survival, which was the cornerstone concept for adapting nephron-sparing surgery in renal cell carcinoma. On conclusion, nephron-sparing surgery for small renal masses and renal cell carcinoma and its impact on kidney function is a hot topic in the literature, but there still need to answer some several questions. One of these, the overall survival, and the other one, the comparison between robotic and endoscopic nephron-sparing surgery and their outcome on renal function. Thank you.
Thank you, Doctora. I would like to call now Dr. Safa Abdali. Safa, huh?
Hello. Hello, everybody. I'm Dr. Safa Abatli, an intern doctor at the Rish Nazal Hospital and a fresh graduate from An-Najah National University. Well, today I'm presenting to you one of the really interesting cases in urology. But before we get into the details of the case, let's just have a quick background about the conditions related to our case. As we all know, the testicular cancer is linked to male infertility. And to be more specific and related to our case, the testicular germ cell tumor is related to male infertility and is most prevalent in young adults aged from 15 to 35-year-old. Cryptorchidism has also been found to be linked to male infertility, which is by itself considered a risk factor for testicular cancer. It is unusual and yet problematic for patients with undescended testes to present in adulthood. Oncologic testicular sperm extraction has been increasingly used for fertility preservation in patients with testicular cancer and has shown successful results. However, few cases were reported with successful results in the presence of multiple risk factors of infertility. Herein, we present a case of 38-year-old male with single left testis, primary infertility for 5 years, and a history of cryptorchidism diagnosed and treated at the age of 30. On physical examination, the patient had two well-healed bilateral inguinal scars and a small scar over the left hemiscrotum. While on the palpation, we palpated the right scrotum to be empty and the left testis was palpable in the left hemiscrotum with a palpable hard nodular mass over the inferior pole of the left testis. Semen analysis showed azoospermia, FSH was high, testosterone was low, LDH, AFP, and beta-HCG were all negative. We did this scrotal ultrasonography, which showed the left testis itself to measure 3.6 by 1.6 by 2.5 centimeters. It was heterogeneous, hypoechoic in appearance, with multiple internal calcific foci. The lower pole of the left testis has a well-defined vascularized and multilobulated lesion that measured 2.2 by 1.3 by 2 centimeters. The patient was prepared for left testicular exploration. A firm mass was found occupying the lower pole of the left testis. A fresh frozen sample was obtained and sent to pathology. Micro-oncologic testicular sperm extraction was done while waiting for the results of the fresh frozen sample. The fresh frozen sample biopsy have shown a 6-cord benign tumor consisting of Leydig cell hyperplasia. The mass was carefully removed and testicular tissue was spared. However, the histological evaluation of the mass itself was evident for seminoma. So the decision of left orchidectomy was proceeded. The procedure of the micro-oncologic testicular sperm extraction was successful and dilated tubules were obtained and sent to IVF centers. To conclude, the whole idea of this research is that successful micro-dissection testicular sperm extraction
A case series of 3 patients. كأنها اعتذرت. طب قول لي قبل.
Good afternoon. I'm going to talk about 3 cases using what's called extreme oncoplastic breast surgery. So in the morning, I presented an overview of oncoplastic breast surgery, and I'm going now to present an extreme oncoplastic breast surgery. Okay, so we mentioned this, breast conserving surgery and mastectomy has similar survival. And oncoplastic breast surgery means using plastic surgery in the treatment of breast cancer in the form of breast conserving surgery. So what is extreme oncoplastic surgery? Extreme oncoplastic surgery means it's a breast conserving surgery using oncoplastic techniques in which in most physicians' opinions, the patient requires mastectomy. And it allows us to treat multifocal, multicentric, and even large tumor for these patients. Okay, so case 1, we've got this lady, she's 36 years old with negative family history. She's presented with right breast lump. Mammogram and ultrasound showed a suspicious multiple lesion extending from 8 to 1 o'clock. So it's a big tumors, it's a multicentric tumors from 8 to 10 o'clock, 1 o'clock, associated with enlarged ipsilateral axillary lymph nodes. Core biopsy showed invasive ductal carcinoma grade 3, ER positive, PR positive, HER2 negative, and she has received new adjuvant chemotherapy, but unfortunately with minimal response. So the original footprint of the tumor remained same. Genetic tests for her were negative. So this is the area that hashtagged with the green is the tumor location, a tumor volume. So what should we do in this case? First of all, I've localized the tumor. So I've put 2 wires. This is called bracketed wires. Then I've done the lumpectomy, which weighted here about 200 grams. Then I did a breast lift, but it wasn't enough. So I've added a volume. I took a flap from her chest wall, the LICAB flap, to reshape her breast. And I did also a breast lift on the other side for symmetrization. So the margins were negative.
1 more minute.
Okay, and this is the photo at the end of surgery. This is after 3 months after radiotherapy, the result, without implants, her own breast tissue. Same condition, this is before. This is a big tumor after new adjuvant therapy. So I've done the same thing, but different flap. And this is after, here after photo. So this is 7 weeks before, after surgery, and 1 month after radiotherapy. The last case, the same thing. She's got 2 tumors, and I can show you. This is in the red circles. So tumor is away like 14 centimeters from the nipple. The other is periolar. So I've excised all the area. And she is here after surgery with the preserved volume and shape. So to conclude things, these extreme oncoplastic breast surgery, which is like an advanced of oncoplastic breast surgery, allow us to avoid mastectomy in many cases of multicentric, multifocal, and large tumors. Thank you.
And now with Dr. Amer Koning. Dr. Amer, he will talk about adherence to oral anti-cancer hormonal therapy in breast cancer patients and its relationship with treatment satisfaction.
Good afternoon. Patient-reported outcomes such as medication adherence and the treatment satisfaction are important to measure, as they hugely affect the success of a treatment plan. And a global agency such as FDA always recommends to conduct multiple types of research about this topic. So today I'm going to talk about one of our research in oncology patients related to adherence to oral anti-cancer hormonal therapy in breast cancer patients and its relationship with treatment satisfaction and clinical factors. As you are aware, breast cancer is one of the most common health conditions faced by women worldwide, and it represents approximately 10% of all types of new cancer diagnosis and affects 1 in 8 women during their lifetime. We adopted a cross-sectional design to achieve the goal of the study, and we included 2 main centers, النجاح National University Hospital and Al-Watani Hospital, between November 2021 and January 2022. We included all breast cancer patients with hormone positive over 18 years of age and has been prescribed or initiated a hormonal oral anti-cancer drug at least 4 weeks before enrollment. However, a patient with comorbid Williams, dementia, or other psychological disorders and hospitalized patients or who were unable to participate were all excluded. Regarding the data collection tool, we use the MARS, Medication Adherence Rating Scale, to assess the medication adherence, which contains 10 items, and the total score ranges from 0 to 10, where a higher score indicating a good adherence to medication. In addition, we use Treatment Satisfaction Questionnaire for Medication, TSQM, version 1.4, to assess the patient satisfaction with the treatment. And this tool assesses the adherence in 4 domains: effectiveness, side effects, convenient, and global satisfaction. It contains 14 questions, and the total score for each domain ranges from 0 to 100, where a higher score denoting a better outcome. Let's move on to our findings. The total number of participants were 106, with the mean age of 52 years old. And about half of our participants have a comorbid conditions, and about 30% of female patients using the tamoxifen, while other participants using the aromatase inhibitors.
Less than 1 minute.
Okay. The median Mars score was 8, and about 62% were fully adherent to their hormonal drugs in the past week. Also, all domains of treatment satisfaction were strongly and positively associated with medication adherence. Also, we found that female patients with comorbidities, chemotherapy treatment, and hormonal therapy switching were also significantly associated with lower adherence scale. In this table, we showed that in a multiple linear regression analysis, and we can find that the side effects domain and the global satisfaction domain were the predictors of adherence scale. To sum up, the current study found that higher treatment satisfaction, especially with regard to side effects, was strongly associated with good adherence. So we recommend creating a specialized scale to measure adherence, taking into account the unique features of this population. Also, our study came up with an important finding that switching hormonal medications was associated with poor adherence, and we recommend that further research is necessary on this point, and clinicians should be aware when switching between hormonal medications. Thank you for allowing me to be part of this.
Thank you. Dr. Hamza Hamayel. He will talk in 3 minutes about diffuse large B-cell lymphoma. Microphone is yours, Hamza.
2 minutes. Assalamu alaikum. Assalamu alaikum. I would like to present a case of unusual mass inside the heart. I would like to present a case of unusual mass inside the heart. Our case is 26-year-old female patient with unremarkable past history. She presented to our hospital with progressive shortness of breath on minimal exertion for 3 months. She had facial, upper limb, and lower limb swelling with no chest pain, cough, fever, night sweat, or other symptoms. Upon presentation, she was hemodynamically unstable. She had borderline blood pressure, tachycardia. She had good oxygenation on room air, but she was tachypneic and in mild respiratory distress. On exam, she had distended neck vein and distended vein in the upper chest, along with chest examination that compatible with chest X-ray that she had bilateral pleural effusion, mainly in the left side. Laboratory investigation, including CBC, kidney function, and other lab were within normal. We did transthoracic echocardiography, which showed a large right atrial mass with severe pericardial effusion. We started supportive treatment. We did pleural drainage to relieve her respiratory distress, and also we did pericardiocentesis to improve her hemodynamic. Then to get further details about this mass, we did transesophageal echocardiography, which showed a large right atrial mass, as we see, with a size around 6 by 6 centimeter, that almost occluding the tricuspid valve. Here, the CT scan, which showed a soft tissue in the right atrium, has a filling defect almost occupying the right atrium and almost occluding that distal superior vena cava. MDT discussion was requested, including cardiologist, cardiac surgery, and oncologist. And according to the patient condition and taking consideration of the patient hemodynamic instability, the decision was to go for surgery to relieve the obstruction and to improve her hemodynamic, and in addition, at the same time, to take a biopsy for histopathology. However, unfortunately, the mass was unresectable, so open biopsy was taken and the chest was closed. Later on, the diagnosis of diffuse large B-cell lymphoma was done, which is a very rare scenario for DLBL to present as intracardiac mass. The patient was started on R-CHOP chemotherapy, and over the next few days, the patient started to improve, her respiratory distress started to decrease, and edema also, and she became hemodynamically stable. And this echocardiography after 3 weeks of hospitalization, which is on the day of discharge, showed a dramatic reduction in the size of right atrial mass. She was discharged after 3 weeks, and then she was given the remaining cycle of chemotherapy as outpatient. She received around 6 cycles of chemotherapy and many sessions of radiotherapy and intrathecal methotrexate. Then she was in regular follow-up in the outpatient clinic, with the last follow-up was 2 years after the diagnosis, showed complete resolution of the mass by echocardiography and no or negative uptake by PET scan, which showed no any hypermetabolic activity or hypermetabolic lymphomatous lesion in the body. Thank you.
Our next speaker is Dr. Nagam Jude. She will talk about antimicrobial resistance in some cancer patients.
Okay. My research was about isolation, identification, and the profile of antimicrobial resistance of microbial pathogens in cancer patients with febrile neutropenia. It's a retrospective cohort study from Palestine. Okay. Okay. Febrile neutropenia is a life-threatening complication of chemotherapy. What's febrile neutropenia? It's when oral time temperature of more than 38.3 Celsius or a sustained temperature of more than 38 Celsius in a cancer patient with chemotherapy with an absolute neutrophil count of less than 500 or expected to decrease to less than 500 cells within the next 48 hours. Okay, we all know that antimicrobial resistance is a big and challenging problem nowadays. Okay, the aim of our study is to determine antimicrobial resistance among cancer patients who developed febrile neutropenia in chemotherapy treatment. Okay, we aim also to better approach febrile neutropenia cancer patients and to give better knowledge about antimicrobial resistance and to decrease morbidity and mortality. Our study was a retrospective cohort study that was done at Oncology Center at النجاح National University Hospital, extended from January 2020 to October 2021. Our population was chemotherapy cancer patients who developed febrile neutropenia. Our sample size was 150 patients. Our instrument was medical records from النجاح National University Hospital archive. Our exclusion criteria was pediatric patients and cancer patients who takes another therapy than chemotherapy, such as radiotherapy. In our results, we have 71.3 patients that didn't have any focus of fever. Our cultures was just positive in 1/3 of our patients. Our organisms that we have isolated, we have gram-positive bacteria to be the most common in around 54%, in contrast to international studies. Then we have gram-negative bacteria to be around 35%. We have also fungi isolates with 30.2%, protozoa with 1.6%, viruses 6.3%, and all of them will COVID-19. We use the multi-regimens of antibiotics as a prophylactic. We have the mostly common used one is levofloxacin, then acyclovir, followed by fluconazole. As an empiric therapy, we have amikacin and piperacillin tazobactam to be the most common used one. As a definitive therapy, amikacin, vancomycin, and ceftazidime were the most common used one. Then piperacillin tazobactam. Antibiotic resistance, Enterococcus faecalis was the most common organism that we have isolated. And it was 33.3% resistant to ampicillin. Among gram-negative, we have Klebsiella pneumonia to be the most common isolated organism, and it was 20% resistant to carbapenems, 40% resistant to cefibimen and trimethoprim sulfamethoxazole, and by 60% resistant to piperacillin tazobactam. According to Pseudomonas aeruginosa, 50% were resistant to ciprofloxacin. Our conclusion, okay, febrile neutropenia is a life-threatening complication that led to 6% of patients to die. We have also some patients that developed some complications such as renal impairment, liver impairment, transfer to ICU, developed shock. Okay, gram-positive bacteria were the most common isolated organisms, with Enterococcus faecalis to be the most common one. Among gram-negatives, Klebsiella pneumonia and E. coli were the most common isolated one. Our recommendations is adherence to antibiotics, works in hospital, not to use piperacillin tazobactam when Klebsiella pneumonia is suspected. And thank you.
Again with Dr. Hamza Hamayel. He will talk about successful treatment for isolated bone marrow Hodgkin lymphoma in an HIV negative patient.
Assalamu alaikum. This is a case of successful treatment of isolated bone marrow Hodgkin lymphoma in HIV negative patient. Our case is 36-year-old male patient with unremarkable past history. He was referred to our hospital from Gaza with generalized weakness, night sweat, and chills for 6 months. He has no other remarkable symptoms. There was a delay in the transfer the patient to our hospital due to barrier restriction between Gaza and West Bank. Our available data from the referral hospital that the patient had pancytopenia with hemoglobin of 4 milligram per deciliter, and he received many blood products there, and the blood film there showed pancytopenia with no other remarkable finding. Upon evaluation in our hospital, the patient was hemodynamically stable, examination was unremarkable with no lymph nodes, spleen and liver also were not palpable. Investigation by laboratory investigation showed by CBC, firstly, he had pancytopenia, hemoglobin of 7.4, white blood cell 2.8, with a platelet around 100, and other laboratory investigation were normal. Blood film showed pancytopenia with no abnormal cells, and bone marrow biopsy showed around 80% cellularity with no blast cell, but showed large multinucleated cells with a prominent nuclei like Reed-Sternberg cell, and after immunohistochemical staining, it was suggestive of Hodgkin lymphoma. We did CT scan, which showed no other peripheral lymph nodes, and spleen and liver also were within normal size. So we have a bone marrow involvement by Hodgkin lymphoma with no peripheral lymph nodes. This is suggestive of primary bone marrow Hodgkin lymphoma, which is very rare. And for this, we sent a second opinion to King Hussein Hospital for confirmation, and they confirm also the diagnosis. This table represents all the published case report of primary bone marrow Hodgkin lymphoma in HIV-negative patients. What was even frightening that all patients had short survival duration, and most of them died within the first month, and the main cause of death was sepsis. As we see, most of them died within the first month. So our plan of management was divided in two main issues. Firstly, regarding the primary bone marrow Hodgkin lymphoma, we started patient on conventional chemotherapy for Hodgkin lymphoma, which is ABVD protocol. And secondary, regarding the sepsis, which was the main cause of death in patients with primary bone marrow Hodgkin lymphoma, we put a very low threshold for diagnosis and management of sepsis. So when the patient developed low-grade fever, we started management for the patient as neutropenic sepsis. Over the next few days, his condition started to improve, all symptoms resolved, and he returned to his baseline condition with good general condition and discharged after 2 weeks of admission. Then he was given the remaining cycle as an outpatient. He received 6 cycles of ABVD chemotherapy protocol. Then he was on regular follow-up in outpatient clinic by laboratory investigation and imaging. With last follow-up was 2 years after the diagnosis, showed completely normal cell counts, white hemoglobin of 13.5, white blood cell 6.5, and platelet 160, with no any hypermetabolic activity by PET scan. Thank you.
Thank you, Doctor. The last poster abstract session will be by Dr. Yazan Obeida, first case of Erdheim-Chester disease in Palestine.
Hello, my name is Yazan Abouide. I'm a general practitioner with a newly obtained medical license. Today I'm going to talk about a very interesting case report in Palestine, the first case of Erdheim-Chester disease in Palestine presenting with bilateral flank pain. Next, please. Next. Sorry. Okay. So, discovery of Erdheim-Chester disease. So, it was thought in the past that the infiltration of foamy fatty cells does not occur except in the skin because of hypercholesterolemia, xanthomas, and xanthelasma. This vision was expanded when children with inborn error of fat metabolism showed depositions of these foamy cells in different organs, like Gaucher disease and Niemann-Pick disease. In 1930, 2 patients in their 50s died of heart failure and were dissected by Erdheim and Chester. The dissection showed deposition of foamy cells in different organs. They both believed this was different from Langerhans histiocytosis. Hans-Schüler-Christian disease is the Langerhans histiocytosis known at that time. It includes the following triad: exophthalmos, osteolytic lesions, diabetes insipidus. Langerhans histiocytosis versus non-Langerhans histiocytosis. Langerhans histiocytosis affects more children with dark red or brown lesions in different organs. The bone involvement is mostly osteolytic, and lung involvement is very common in comparison to non-Langerhans histiocytosis. And osteolytic lesions and lung cysts, as I said. And Erdheim-Chester disease affects more adults with xanthomas, lipids, xanthogranulomas, and osteosclerotic lesions. It affects mostly kidneys, aorta, and bone. The fact that only 1,500 cases were reported by 2020 since the discovery of this disease justifies its rarity. Pathogenesis. BRAF V600E mutation in the bone marrow. This will form the histiocytes. These histiocytes will migrate and infiltrate different organs in the body. They're gonna recruit inflammatory cells through interleukins, and this will cause the destruction of the affected organs. These are the references. A 54-year-old woman with pre-past medical and surgical history came to the ER complaining of bilateral flank dull pain for 6 months. There was no radiation to any other place in the body. The pain was moderate, and the patient decided to seek medical advice because of its long duration and the fluctuation in intensity. She denied fever, hematuria, or history of renal stones. Anorexia and weight loss were confirmed by the patient. Physical examination were normal except for bilateral flank tenderness. Urine analysis showed microhematuria. CBC showed microcytic anemia. The patient also had elevated creatinine level. Ultrasound, left kidney showed hydronephrosis. The right kidney showed an echogenic mass with a diameter of 3.2 centimeter. Heteroechoic kidney with loss of cortimedullary differentiation, echogenic fatty planes, and free fluid in the perinephric space. The next day, CT scan for the chest, abdomen, or pelvis was done. Kidneys showed bilateral hairy kidney sign with few bilateral cortical cysts with calcified walls, right needle mass, aorta-coated aorta sign, heart, mild pericardial effusion, bone osteolytic lesion in T12, osteoblastic lesion in the right iliac bone, liver, hepatomegaly, and ureter involvement of the proximal part. This is a CT scan for the patient, a slice for the patient. We see the perinephric fatty infiltration there. It appears like hair. This is why it was called hairy kidney sign. And this infiltration, we can see it around the aorta too. This is another picture. A biopsy was taken from the needle mass and showed an infiltrate of homihistiocyte admixed with scattered lymphocytes and plasma cells, positive CD68, negative CD1A S100. I will explain this in seconds. This is the pathology slide. This is the slide of immunostains for CD68. A BRAF V600E mutation inhibitor is recommended for the patient. And this is the first case of Erdheim-Schuster's disease in Palestine. Second reported case worldwide of a renal mass. One of the few cases with axial skeleton involvement. One of the few cases with osteolytic lesions. Countable cases mentioned an association between osteolytic lesions in the axial skeleton and liver involvement. Hydronephrosis is mostly due to retroperitoneal fibrosis. However, our patient had hydronephrosis due to proximal ureteral involvement. The mild pericardial effusion should not be neglected as there was a case of cardiac tamponade in ECD patient. The periaortic infiltration can lead to rupture. CD86 positive, this means that we are dealing with a histiocyte. When S100 CD1A negative, R negative, we are dealing with non-Langerhans histiocytosis. Conclusion, a 54-year-old woman came to the ER complaining of bilateral flank pain. CT scan showed hairy kidney sign, which is pathognomonic for Erdheim-Schuster disease. The biopsy confirmed the diagnosis. The presentation of the disease was very indolent and insidious. Up to our knowledge, this is the first case of Erdheim-Schuster disease in Palestine to be reported. Thank you very much.
Thank you very much. Is Dr. Firas here? Please, come.
Can I ask a question, Dr. Haytham? Yeah. I want just to ask a question. I want Khalid, Dr. Sharaf, Dr. Khalid, thank you very much for both presentations. I think they are really nice. I have a couple of questions, if you don't mind. The first one is about the extreme oncoblastic surgery of breast cancer. My question is really there any justification that you want to do this extreme oncoblastic, which is multiple resections, prolonged surgery, risk of positive margins, instead of doing total radical mastectomy and bring the patient in 6 weeks or 3 months time for reconstructive surgery in a different stage? So why do you think this extreme oncoblastic is better than, I measure like if I'm going to do multiple kidney tumors, or just take the whole kidney out rather than to do complete reconstructive surgery for multilocal disease.
Thank you. Very good question indeed. So, preserving the breast is better than any reconstruction, any type of reconstruction. So we've got autologous reconstruction, I mean taking tissue from the body itself, or implant-based reconstruction. Now, why am we trying to go for these extreme oncoplastic rather than mastectomy and reconstruction? And this is the question, very important question. First of all, the more you do oncoplastic surgery, the more you start to think, why just not to preserve the breast? Because what we need in a breast surgery is negative margin. So if you achieve a negative margin, that's okay. That is what we want. Now, yes, there are some complications, but complications of reconstruction is much more than oncoplastic surgery, especially if you are going to give the patient radiotherapy after surgery. And especially if you are going to use implant-based reconstruction. Now, you are talking about delayed reconstruction when you talk about just take the tumor out and do delayed reconstruction. Well, we can do it for some patients, okay? But immediate reconstruction is much better than delayed reconstruction for the patient, from the physical body and also psychologically. Delayed reconstruction, it will be delayed for months. When we call delayed reconstruction, the patient is going to have maybe adjuvant chemotherapy, adjuvant radiotherapy, and this will delay the reconstruction for a month. And in this case, she might need autologous rather than implant-based reconstruction.
And is this extreme oncoplastic surgery feasible for lymph node positive?
Yes, yes, sure. So axillary surgery is different from oncoplastic surgery. So what you can do on axilla is different from what you can do on the breast. So you can do sentinel with extreme, you can do dissection with extreme.
So you deal with the breast and axilla as two different entities?
Yes, yes.
Okay, thank you very much. And that will take me to Safa. So I have another question similar to... No, there's another question, just one question. Please, can I have another question? Can I have another question? Just one question. Because I think Safa has presented a case, which is a testicular tumor in undescended testicle. And the surgeon there, he excised the whole testicle and he did like sperm extraction for a functional part of the body, while the breast is not a functional part. What I mean, testicle, kidney, they are testicle producing hormone, kidney, it's vital for kidney function. And as urologists, we excise kidneys when there's 2 or 3 tumors. And as in your case, you excise the testicle and you take some seminiferous tubules instead of preserving the kidney and do extreme testicular preserving surgery in comparison to the breast. So why do you think the surgeon in your case decided to take the testicle and extract some sperms rather than doing partial orchidectomy and keep the testicle inside?
Yes, Safa, please. It
Well,
was a good topic you presented, but the question is very valid.
yeah, after the excision of the mass and sending it to the pathology, the results showed seminoma, which is malignant testicular tumor. So the risk of seeding will be really high if they did not perform the total orchidectomy. So the decision of left orchidectomy was taken to prevent the seeding of the tumor.
Satisfied with the answer, doctor? No, he is not satisfied, Safa. I think you can discuss it together later on. Any further question? Any other question? There is no gala dinner if there is no 3 more questions. Please. ميكروفون للدكتور. اضويه من تحت دكتور، لفه من تحت.
I want to ask about the case of Hodgkin lymphoma with pancytopenia. We know that a patient of Hodgkin lymphoma with pancytopenia, it is a stage 4. I think if it is enough to start with the protocol ABVD in patient with Hodgkin lymphoma stage 4. Thank you.
To whom is the question?
نعم.
The question is directed to whom?
I want to ask if it is enough to start
with EBVD protocol with a case of Hodgkin lymphoma stage 4?
Who can answer his question? Hamail, Hamza.
Hamza.
مستحي حمايل مش عارف ليش.
Yes, it's enough. In stage 4, yes, it's enough ABVD protocol chemotherapy for 6 cycles, it's enough for it. However, our case, the rare scenario in our case that it's primary bone marrow Hodgkin lymphoma, which is there is no established protocol management for those. Anyway, we treat him as stage 4 Hodgkin lymphoma.
Thank you. I would like to thank the moderators, the secretary, and the audience, and all the lecturer. Thank you very much. See you in the gala dinner. You know where is it?
احكي لكم على الجالا. شكرا جزيلا. طبعا نختتم اليوم الاول. الجالا دينر هو في دبليو ريستورنت جنب مطعم ألف ليلة وليلة، بيبعد عن هون 10 دقائق بالسيارة. معروف منطقة ألف ليلة وليلة وحياة نابلس، هو الريستورنت الجديد اللي هناك. وإذا في حدا معوش سيارة ومش عارف كيف يوصل، أنا باخده معي بسيارتي. على 7 بدنا نجتمع، 7:30 رح يبلش الأكتيفيتيز. على 7 يعني معنا نص ساعة، يعني معنا نص ساعة زمن.